Today, Dr. Yuvraj Bhosle sir, our registered delegates, my colleagues, junior and senior, and my dear students. I welcome you all to the inauguration of this webinar, Anatomy through Radio Imaging Techniques, which was visualized and conceptualized by our ex-head of the department, late Dr. K. Shyam Kishore sir. Unfortunately, we lost sir to the cruel hands of fate on 11th December 2025. Sir's guidance and presence is being missed by all of us today, and we carry on his vision and his legacy, and in sir's own words, the show must go on. We offer our heartfelt tribute to sir and begin with seeking blessings of Lord Ma Saraswati, for which I invite our very own Nightingale of Anatomy Department, Dr. Sneha Shah.
A very good morning to everyone. I request everybody to please join your hands and close your eyes. Saraswati Namostubhyam Saraswati Namostubhyam Varade Kamarupini Vidyarambham Karishyami Siddhi Bhavatu Me Sada Saraswati Namostubhyam Saraswati Namostubhyam. Thank you.
Thank you, Dr. Sneha, for this melodious rendition. And to begin with the formal inauguration, I would like to invite on stage our respected Dean Sir, Dr. Moiti Sir, our invited faculty, Dr. Nimesh Kamath and Dr. Sameet Patel, our head of the department in charge, Dr. Yuvraj Bhosle Sir. I request you all to please be seated, and I request our HOD in charge, Dr. Yuvraj Bhosle sir, to please extend a floral welcome to all our invited guests. First, our respected Dean sir, Dr. Moite sir. To Dr. Nimesh Kamath sir. Thank you, sir. And to Dr. Sameet Patel. May I now request Dr. Yuvraj Bhosle sir to deliver a welcome address.
So, respected Dean sir, respected faculty on the dais, all the participants who are attending this webinar across India, across the world, we are so happy here to have this webinar, and we are really thankful to you for registering in such large numbers. We are going to cross 500 participants, and we plus have our students sitting here so enthusiastically to attend this session. Anatomy, what we study in first year is on the cadaver. Second year onwards, we start seeing the same anatomy live in endoscopy rooms, in the operation theaters, and then we realize there is difference in the anatomy what every medico studies in first year and what he studies in second year, third year, and in the super specialization. But its anatomy remains same, only the view changes, something like, I would say in your language, it's a pro view what we get when we see the same anatomy live. And that is the experience which Department of Anatomy, TNMC wants to offer to all of you. And we have been consistently arranging webinars under guidance of our previous HOD, Dr. K. Shyam Kishore, and we promise that we will continue such kind of interesting webinars for the undergraduate students, postgraduate students, super specialists, and the general practitioners also. So with that few words, I welcome all of you, welcome our Dean Sir and the speakers. Thank you.
Thank you very much, Dr. Yuvraj sir. Leaders instill in their people a hope for success and a belief in themselves. A great leader knows how to translate vision into reality. We all look up to our leader, respected Dean Sir, Dr. Shailesh Moite sir, in a very similar manner. Sir has been closely associated with Nair for a very long time now, first as a professor and head of forensic medicine until he took up the position of Dean of HBT Medical College at Cooper Hospital, and now we are fortunate to have him back at TNMC as our Dean. Lately, sir has also taken up the position of director, so we are fortunate to have the director with us at Nair here. Apart from forensic medicine, his skillful administrative techniques are powered by a problem-solving attitude, which has brought about significant change in patient management and healthcare services. As a Senate member and member of Board of Studies at MEHS Nashik, he's a great academician in pursuit of excellence. I now request Dean Sir to deliver the inaugural address.
A very good morning to all of you. At the outset, I congratulate the Department of Anatomy for holding such type of activities to impart additional knowledge. I have seen the program and I am impressed with the topics that have been included in the program to introduce students and practitioners to radiological imaging. One thing which I feel is medical students attending should, after this, whenever they go for their radiology posting, to see how all these modalities actually function, how does the machine look, the CT scan machine, MRI machine, and how does it function. Because these are certain things which most of the departments lack in introducing to the students. So during your radiology posting, you should see this. The speakers are eminent ones in their field, and after years of practice related to their topics, they have gained excellence, and I'm sure their experience and talk will benefit all of us a lot. My best wishes for this program. Thank you very much.
Thank you very much, Dean Sir, for your guidance and encouragement every step of the way in organizing this webinar and in sparing your valuable time for its inauguration this morning. On behalf of the Anatomy Department, I also extend a heartfelt gratitude to our esteemed faculty who are sharing their treasures of knowledge on our webinar platform. We are grateful to Dr. Ashwin, who amidst his busy schedule is participating online. We are deeply indebted to Dr. Nimesh Kamath and Dr. Rahul Bakaria and Dr. Samit Patel, who are delivering their lectures in physical presence. And special gratitude to Dr. Omkar Auti, who is coming all the way from Pune to deliver his lecture. For him and Dr. Samit, I think it feels more like homecoming, as they both are Nair alumni and have been our students here. It's a proud moment for me to have them here as faculty. I thank the entire organizing team of the CME who have worked tirelessly and selflessly behind the scenes for conducting this program so smoothly. It includes our guiding force, our star in heaven now, late Dr. K. Shamkishore sir, our organizing chairperson, Dr. Yuvraj Bhosle sir, our organizing secretaries, Dr. Nagraj, Dr. Shubhangi, who are associate professors, and Dr. Vivek and Dr. Kavita, who's assistant professors here in our department. Thank you, Dr. Sneha, for rendition of Ganesh Vandana, and our team of PG students for helping us out every step of the way. The success of this webinar and my speech is incomplete without recognition of the contribution by our delegates and participants and our dear students who have made all our efforts worthwhile. Thank you very much, sir. We come to the end of inauguration, and I thank sir for your valuable presence here, sir. Thank you. We are just in time to begin with our first talk, and it's my pleasure to introduce our first speaker, Dr. Sameet Patel, whose academic brilliance shines in all the awards and accolades he has been awarded, which include the S.K. Sama Gold Medal by the President of India for securing All India first rank in DNB Gastroenterology, Young Investigator Award by Indian Society of Gastroenterology, All India TYSA Award for Gastroenterology, Best Orator Award at All India TYSA, Young Achiever Award at GiftCon. Dr. Sameet Patel is currently Assistant Professor in the Department of Gastroenterology at TNMC and BYL Nair Hospital, Mumbai, with special interest in motility disorders and inflammatory bowel disease. I invite now Dr. Sameet to demonstrate and enlighten us about the endoscopic appearance of gastrointestinal tract and biliopancreatic ductal system. Over to you, Dr. Sameet.
Good morning, everyone. So my topic for today is endoscopic appearance of the gastrointestinal tract and the biliopancreatic system. So it's going to be basically divided into three parts. The GI tract will be covered by gastroscopy and colonoscopy. The upper GI tract will be covered by gastroscopy. The lower GI tract will be covered by colonoscopy. So those will basically include endoscopic images mainly, which I'll be showing the more or less the normal anatomy and few images of pathology. The biliopancreatic system will be covered by a few EUS based images, and I will try to show you short videos of each of them. So to begin with, the GI tract consists of various parts beginning from the oral cavity to the pharynx, then the esophagus, the stomach, the small intestine, colon, rectum and anal canal. So the esophagus, stomach and the proximal duodenum is what we mainly visualize during a gastroscopy or upper GI endoscopy, and the rectum and the colon is very focused during a colonoscopy. So beginning with the gastroscopy, as you introduce the gastroscope, you pass the tongue and the here this is the base of the tongue and this is the uvula. So as you pass that, you can see the epiglottis, and after passing the epiglottis, here you can see these are the true vocal cords. This is the epiglottis, this is the arytenoids and the arytenoids fold, and behind this is where you pass the scope to reach the esophagus or the upper esophageal sphincter. So as we reach the beginning of the esophagus, this is the upper esophageal sphincter. It is generally at approximately 15 centimeters from the incisors. So we need to apply gentle pressure as we introduce the gastroscope across the upper esophageal sphincter. Following this, we enter the esophagus. This is the normal appearance of the esophagus. So this is the mid-esophagus. Then we proceed to the lower esophagus, where you have multiple linearly arranged blood vessels. They are present proximal to the GE junction. Then moving on to the gastroesophageal junction. So you have the squamous epithelium that is present in the esophagus and the columnar mucosa which lines the stomach. So you can see the clear differentiation at the squalo-columnar junction from the difference in color and the epithelium. So the GE junction has three components. We have the mucosal change, that is the squamo-columnar junction. Then you have the ending of the proximal gastric folds, and you have the diaphragm pinching the lower end of the esophagus or at the GE junction. So these are the three components. One is the diaphragmatic pinch, one is the proximal extent of the gastric folds, and the third is the squamo-columnar junction, which I've shown you. So there is a possibility that they'll overlap. So here you can see the diaphragmatic pinch, that is where the esophagus is getting narrowed to continue into the stomach, and the squalo-columnar junction, that is a change in the color from light pink to dark pink or whatever, as you can see. So these are some pathologies of the esophagus. I don't know if there's any scope for interaction, but at least if the UG students here, if it is possible, what is this pathology? This is the esophagus. So you can see linear erosions and ulcers here. So any idea? So this is basically gastroesophageal reflux disease, which is probably the most common pathology and the most common patients that we deal with. This is the classical endoscopic appearance, although it may not always be present. Moving on to this is Barrett's esophagus. So as you can see this, the gastric mucosa or the pinkish mucosa has extended upwards into the lower part of the esophagus. So this is the tongue-like projection, which is classical of Barrett's mucosa. Of course, you have to biopsy it and prove the intestinal metabolism. So this is, you can see a mass here with ulcerations. So this is carcinoma of the esophagus. These you can see the large dilated veins here. So these are the esophageal varices, which is seen in chronic liver disease. Here you can see the esophageal varix is bleeding. So this is where our endotherapy is of maximal benefit, where we just put a band over this bleeding portion and the bleeding stops, and it is life-saving for the patient. These are various foreign bodies that are ingested by patients. With the help of different devices and forceps, we are able to remove them with the help of a gastroscope. So we finished the stomach, the esophagus. Moving on to the stomach. So this is a diagrammatic representation of the stomach. Here you can see the cardia. So just as you cross the G junction, the first portion of the stomach that you see is the cardia. Then moving on to the fundus. So after you entered the stomach, you rotate the scope by 180 degrees, and in retroflexion you can see this is the G junction from where the scope has come, and you've come and taken a U-turn. So you can see the upper part of the stomach or the fundus here. Moving on to the body and the antrum, which are separated by this angle or the incisura angularis. So this is the upper part of the body. You can see the body of the stomach has these folds or the rugae of the stomach, which can be seen normally. So this is the upper part of the body, this is the middle third of the body, this is the lower part of the body. You can see the body is transitioning into the antrum here, and that is where the rugal folds of the body end. So this is the antrum. The opening is the pylorus or the pyloric canal, and this is the incisura of the stomach, which separates the body of the stomach from the antrum. So the stomach has two curvatures. This is the lesser curvature and this is the greater curvature. So here you can see this is the lesser curvature, this is the greater curvature, this is the anterior wall of the stomach, and this is the posterior wall of the stomach. So whenever we do any endoscopy, if we find a pathology like a growth or an ulcer, it is helpful for us to say that ulcer is seen in the body of the stomach over the anterior wall. So it helps someone who reads the report understand anatomically where exactly the lesion is located. So moving on to the duodenum. So mainly during the upper GI endoscopy or gastroscopy, we can visualize the first and the second part of the duodenum. So this is D1 or the first part of the duodenum, and this is the second part of the duodenum. So the second part of the duodenum is characterized by these circular folds termed valvular conniventes. So this is the normal folds and villi that you can see in the second part of the duodenum. It is very important because it is often these folds are lost in various diseases like celiac disease. And the second part of the duodenum also has the major papilla where the common bile duct and the pancreatic duct join and they drain. And so here in this diagrammatic representation you can see this is the major papilla. Above here, more proximally or more towards D1 is the minor papilla. So the minor or the accessory pancreatic duct drains over the minor papilla, and the main pancreatic duct and the common bile duct join and drain in the major papilla. So the major papilla is present over the medial wall, and this opposite to that, this is the lateral wall of the duodenum or the second part of the duodenum. So the jejunum is not normally visualized during upper GI endoscopy, but sometimes what we do is we use a colonoscope and we put it through the mouth because it is longer if we want to go deeper into the intestine. So in those situations, you can reach the jejunum. It is known as push enteroscopy. So here you can see the normal jejunal folds. So you can see that they are more frequent in comparison to the duodenal folds, and they are thinner. So if you see, this is the normal duodenal mucosa and this is the normal jejunal mucosa. So you can differentiate, especially once you're used to it. You also have single balloon, double balloon enteroscopes which go deeper into the jejunum and sometimes even up to the proximal ileum, but they are less frequently used. So again, moving on to a few pathologies of the stomach and the duodenum. So here I had initially shown you the images of the stomach, so I don't know if you recollect. So you can see that the stomach has nice rugae present here, and if you see this image, they are all lost. So this is basically seen in gastric atrophy. This with the antral region, so you can see these reddish or erythematous and hemorrhagic lines here. So this is classical of GAVE or gastric antral vascular ectasia. It is also known as watermelon stomach. I think this is quite classical. These are gastric ulcers in various parts of the stomach. So all of them are clean based. You can't see any bleeding vessel or any spurting. So if during a scopy you visualize an ulcer, a gastric ulcer, will definitely biopsy it because you'd want to rule out malignancy. And if there is some bleeding, then that will be an indication for therapy where we can use various methods, like we can either put a clip on it or we can burn it using APC or gold probe coagulation. So here you can see this is a diaphyseal lesion. So this is a vascular part which is bleeding in the stomach. And again, these patients present with upper GI bleed, either hematemesis or melena, and it can either be clipped or in this situation you put a band around it to stop the bleeding. This is the vascular ectasia, again will present with upper GI bleed, and it has been burnt here using this is what is a argon plasma coagulation or APC. This is the stomach view in retroflexion after taking a U-turn after entering the stomach. This is the G junction. Here you can see this is a vascular area. These are gastric varices which are again seen in chronic liver disease and portal hypertension. Here you can see there is this large growth that is seen. So this is suggestive of gastric malignancy, which is of course confirmed after biopsy. Here we are in the second part of the duodenum. You can see loss of the normal folds and scalloping of the folds that can be seen here. This is classical of celiac disease, though it may also be seen in other pathologies, and you need to do biopsy, serology, and clinical correlation to confirm your diagnosis. So this is a video of a normal gastroscopy. So here you can see the vocal cords and the arytenoid folds and the epiglottis. Okay, so now we're going to pass our gastroscope behind and reach the upper esophageal sphincter. So we've entered the esophagus. This is the normal esophageal mucosa. As we pass from the esophagus towards the GE junction. So this is the GE junction. So this is where the diaphragmatic pinch is. This is the squamocolumnar junction, and these are the proximal gastric folds here. So the three parts of the GE junction, that is the squamocolumnar junction, the diaphragmatic pinch, and the proximal gastric folds. So as we pass the cardia and enter the stomach, this is the body of the stomach where you can see the normal rugae or gastric folds that are seen. As we enter the antrum and move towards the pylorus. So we are entering the pylorus. Once you enter the pylorus, you reach D1. That is the first part of the duodenum. And now we've gone into the second part of the duodenum where you can see the normal duodenal folds. Okay, so I've finished the first part, that is gastroscopy or upper GI-scopy. Now I'm moving on to the colonoscopy or through the normal anatomy of the lower GI tract. So the large intestine consists of a colon and rectum. The colon is a tubular structure approximately 150 centimeters in length. The cecum is the first part of the colon, which of course leads to the terminal ileum. Then you have the ascending, transverse, descending and sigmoid colon. The ascending colon is on the right side, roughly 20 centimeters in length. The transverse colon crosses the abdomen horizontally, is 50 centimeters. And the descending colon is on the left side, which is approximately 25 centimeters. The sigmoid colon is S-shaped, roughly 40 centimeters and most mobile. So while doing our colonoscopy, these lengths of the various colons don't really matter, and sometimes it becomes really confusing what part of the colon you actually are in until you reach the cecum and you visualize the appendix and the IC valve. But for descriptive purposes, of course, there are various landmarks that we do come across, which I'll be showing you all subsequently. So the colonic musculature has three external longitudinal muscle bundles or tinea coli. Internal to that, there are the circular muscle fibers. The distal colon does get a little thicker in terms of the circular musculature, and the lumen of the colon is divided by haustral folds. So you have the tinea coli, which are longitudinal muscle bundles, and then you have the haustral folds, which divide the colon into segments. So here you can see endoscopically the three tinea coli, the muscle bundles that run longitudinally. At least this one is quite clearly visible. And here are the haustral folds that you can see. So they keep dividing the colon into segments, and sometimes you have to wait for the peristaltic movements to pass to negotiate your colonoscope further. So going from the rectum to the terminal ileum. So beginning in the rectum. So the rectum is a tubular organ, straight in its course, roughly 12 to 15 centimeters in size. It is divided by valves of Houston, that is the superior, middle and inferior rectal folds, and the veins are slightly more prominent in comparison to the rest of the colon. So here you can see the three rectal folds, superior, middle and inferior rectal folds that are normally visible in the rectum. So once we've entered the rectum, again we can rotate our scope 180 degrees and visualize, or 360 degrees, seeing where we have introduced the scope from. So this, on retroflexion, this is the anal canal and this is the distalmost rectum. So this is the anal opening from where you introduce the scope. So you can see the endodermal origin of the distal rectal mucosa transitioning to the cutaneous part, which is derived from the ectoderm. So here you can see again, this is a retroflex view. This part is the rectum or the distal rectum. Then you can see the junction of the rectum with the anal canal, which is divided by the dentate line. So this is a anatomical diagram where you can see the external anal sphincter, the internal anal sphincter, you have the external and internal hemorrhoidal plexus, and you have the columns of Morgagni. So basically these anal glands open in these crypts, and this is of pathological relevance because when these get blocked is when you develop an abscess here, which is extremely painful and most of the time has to be drained. And once these abscesses can get complicated, that they can lead to fistulae, where you can have one opening downwards on the skin outwards, or opening here internally, and another opening up here in the rectum. So these fistulae can be quite complex and difficult to manage. So we've moved from the rectum upwards into the sigmoid colon. So the sigmoid colon is basically the most mobile part of the colon, and if you're not careful while doing a colonoscopy, you can keep looping in the sigmoid colon, and you may introduce as much as say 70, 80, 100 centimeters of your scope, and you'll still be going round and round in the sigmoid colon because it is distensible and it keeps elongating. So it is very important that we keep shortening the scope when we are in the sigmoid colon. So it is S-shaped, most mobile segment, suspended by the sigmoid mesocolon, and it is a common site for redundancy and volvulus. Moving on to the descending colon. So as I said, the descending, transverse, ascending colon, maybe in the sigmoid colon, endoscopically they are quite similar more or less. There are differences which I am going to say, but not very, very drastic differences. Like in the stomach, you have a completely different esophagus, stomach, duodenum. So here the differentiation in the different parts of the colon is slightly more difficult while doing an endoscopy or a colonoscopy. So the descending colon forms a long tube and is featureless or comparatively less features to the other part of the colon. It extends from the sigmoid colon to the splenic flexure, and it is fixed. So it is fixed retroperitoneally, so here you have less scope for looping and struggling during the scopy. The scope here is lesser. So as you pass the descending colon, you reach the splenic flexure, which can be seen by this bluish hue, which is seen by the impression of the spleen. So after you reach the splenic flexure, you negotiate the flexure and you reach the transverse colon. So the transverse colon has these characteristic triangular folds. So this really helps you identify that you have reached the transverse colon. Then at the end of the transverse colon, you reach the hepatic flexure, where you can see the liver impression. I think here it is quite clear. It is a darkish hue from the adjacent liver. After negotiating the hepatic flexure, you reach the ascending colon. It has triangular to semicircular folds. So again, not very drastically different from the transverse colon if you see, but here there are more triangular folds in comparison to the ascending colon, where maybe not as evident or not as triangular, but it is difficult to differentiate. So as you proceed through the ascending colon, you reach the cecum and the IC valve. So at the cecum, the three muscle bundles or the taeniae coli join, and here you can see the slit-like opening of the ileocecal valve. So this here and this region here. So the cecum is this region where, as I said, the three taeniae coli meet and the IC opening is present, and it's quite frequent to see this fluid accumulation present in the cecum. So once you reach the cecum and the IC valve, you introduce the scope via the IC valve into the terminal ileum. And this is the fine granular normal mucosa of the terminal ileum that you can see here. The cecum, of course, has the appendiceal orifice that can be seen as a slit-like semilunar structure seen here. So what is also helpful is this part where it points is generally where you can find the IC or the ileocecal valve. So just to recap, you begin with the anal canal, you proceed through the rectum which has the 3 folds, you then enter the sigmoid colon. From the sigmoid colon, you go to the descending colon, then you reach the splenic flexure and you go into the transverse colon. From the transverse colon, you reach the hepatic flexure, then the ascending colon, then the cecum. At the cecal base, you can see the appendix, the IC valve, and then you enter the terminal ileum. So again, these are images of few pathologies. So here you can see the normal vascular pattern in the colon, but here you can see the significant ulceration can be seen. So this is classical of ulcerative colitis. You definitely have to correlate clinically and take biopsies to confirm your diagnosis, but with experience it's quite clear that this looks like ulcerative colitis. This is again inflammatory bowel disease, but this is more classical of Crohn's, where the ulcers are slightly more longitudinal. So this is diverticular disease of the colon. Here you can see diverticula here and here. These are, you can see numerous polyps present in the colon. So this is classical of FAP, or familial adenomatous polyposis. Here you can see a large growth, which is classical of malignancy or carcinoma of the colon. This is probably the most common pathology we find in the colon, and you can see these are polyps. So generally when we find these polyps, what we do is we do something known as a polypectomy. So we take a snare or a loop, we put it around this polyp, and we then close the snare, and with the help of our RB, we coagulate the base, and then we retrieve the cut polyp and we send it for histopathological evaluation. If there's bleeding at the base, we may apply a clip after polypectomy. So this is a video of a normal colonoscopy. So we are passing from the rectum, the rectosigmoid junction, into the sigmoid colon. So from the sigmoid colon, we are entering the descending colon. So this is all the normal vascular pattern that you see during colonoscopy in the colon. So generally a colonoscopy, if done well, keeping the scope in a short loop, takes approximately around 8 to 10 minutes to reach the cecum. And then you are required to withdraw the scope slowly so that you don't miss any pathologies. That again takes another, say, 6 to 8 minutes. And withdrawal is very important, because during withdrawal is when we assess behind every fold if we have missed any polyp or any other pathology. So we are negotiating through the descending colon. We've reached the transverse colon. You can identify it by the classical triangular folds. So colonoscopy involves a lot of pull and push. As I said, the scope sometimes gets stuck in a loop, maybe in the sigmoid colon, and then you have to get the scope to straighten so that you can move further. Otherwise you're pushing the scope, but actually the scope is looping in the sigmoid colon and you're not making progress further. So here we have reached the ascending colon. Again, you can see these normal folds that are seen, semicircular, triangular folds. And fluid is generally seen in the cecum. So this is probably the cecal area. Yeah, so this is the appendix. This is the IC valve here, and this is the cecum. So we have negotiated across the IC valve to enter the terminal ileum. Okay, so I have finished gastroscopy and colonoscopy and the upper GI and the lower GI endoscopic images. I am now proceeding to the EUS based anatomy to cover the pancreas and the biliary system. So, to begin with, the EUS or endoscopic ultrasound, so this might be slightly more difficult because you are not used to ultrasound to begin with, and endoscopic ultrasound gives a very different kind of a anatomical orientation because the scope is in the GI tract or in the esophagus or in the stomach, and from there you are doing a ultrasound and rotating the scope, so it gives a very different anatomical orientation and it takes some time to grasp. So definitely for someone who's not used to it, it will be a bit difficult to understand. I'll try to simplify it as much as possible. So the endoscopic ultrasound consists of, we have two types of scope. One is a linear scope and one is a radial scope. So in your linear scope, it gives you only a 120 or a 180 degree view, whereas the radial scope has a 360 degree view. A linear scope is better for locoregional evaluation, and the linear scope has a channel via which you can introduce your therapeutic instruments like say a fine needle biopsy. You can take a biopsy or you can do further therapeutic procedures that is only possible in the linear scope. The radial scope has a 360 degree view and it is like at every level you get a cross-sectional view. So it may be a little easier to understand, but it only has diagnostic utility. So overall the radial US scope is being used quite less nowadays because it lacks therapeutic ability, and what we are mainly using or restricting ourselves to is the linear scope because it helps in both diagnosis and therapy and biopsy, which is quite crucial for our evaluation and management. So the various, so these are the layers that you can see when you do a radial EUS. So you have 5 layers. The first one is the first layer is hyperechoic or the superficial mucosa. The second is so the first is hyperechoic. So this is the image. where you can see the alternating hyper and hypoechoic layers. So the first layer is hyperechoic, which is the superficial mucosa. The second is hypoechoic, which is the deep mucosa or the lamina propria and the muscularis mucosa combined. The third layer is again hyperechoic, which is the submucosa. The fourth layer is hypoechoic, that is the muscularis propria, and the fifth again is hyperechoic, which is the serosa, the adventitia. So to remember, basically it's alternating hyper and hypoechoic layers. How I remember it is basically wherever you get muscle is where you have a hypoechoic area. So the deep mucosa or the lamina propria and muscularis mucosa appear hypoechoic, and the muscularis propria appears hypoechoic. So the other layers that you get are hyperechoic. So here this is a US image with the 5 layers of the GI tract showing the various histology. So number 1, as you can see, is the mucosa here, which appears hyperechoic. The second layer is the muscularis mucosa, which is here, which is hypoechoic. So this part, which is hypoechoic. Then the submucosa, which is layer 3, which is again hyperechoic. Then layer 4, which is the muscularis propria, which is hypoechoic. And then the serosa, the adventitia, which is again hyperechoic. So frequently during an endoscopy, say a normal gastroscopy, we'll find a bulge in the mucosa. So that is a submucosal lesion. So in that case, what we do is we take the EUS or the endoscopic ultrasound and we see from which layer the lesion is arising. So it helps us in diagnosis depending on which layer the lesion is arising from. So to decide that, you need to know these normal layers, which are alternating hyper and hypoechoic layers with the two muscles, that is the muscularis mucosa and the muscularis propria, being the hypoechoic layers, which are separated by the various hyperechoic layers. So this is the linear US scope. So as you can see, this is how it is shaped. This is the transducer probe, and this is how the rays of 180 degrees. So depending on the company, it may either be 180 degrees or it may just be 120 degrees, your US scope. So this is how you introduce it, and this is your field of vision. So if you put the scope like this into the esophagus and it is facing this way, you're looking at this much region. So it is giving you kind of a sagittal view. Whereas if you would put a radial EUS, then it would give you a cross-sectional view. But as I said, because the radial EUS does not have this therapeutic channel via which we can introduce the needle and do therapy, it is very minimally used right now. So this is what we basically use, that is our linear EUS. This is the scope, this is the channel, this is the transducer, and this is your field of view, which is where, and this is from where the needle comes. So linear EUS images align with sagittal imaging. So if your longitudinal structure is seen, it will appear linear or tubular, whereas horizontal structure will appear oval or as a cross-sectional, because these are how your rays are going. So suppose a vessel is moving like this, from up to down, then you will see a straight tubular structure. But if the vessel is moving like this, you will just see a cross-sectional or an oval view of it. So to do endoscopic ultrasound, what we follow is a station-wise approach for whatever evaluation you are doing, even for pancreaticobiliary evaluation. So at each station, so these are the various stations. The first station is the G junction or the lower end of the esophagus, from where you proceed into the proximal stomach. Then D1 or the duodenal bulb is your next station, and D2 or second part of the duodenum is your third station. So these are your three main stations from where you visualize the various structures. So again these are the same three bases: the stomach or the lower end of the esophagus, the duodenal bulb or D1, and the second part of the duodenum. So what is important in endoscopic ultrasound is, for each station or whichever area you are, you pick up a landmark. So that is your base camp. So you start, say, at the stomach from the aorta, and then you rotate your scope and see different parts, and sometimes you get lost, so then you come back to the aorta and start again. So for the stomach, the landmark is the aorta. From the stomach you can visualize the most of the pancreas, the body, tail and most of the head, the left lobe of the liver, the left kidney, spleen and the liver hilum. For the gallbladder you have to go more distally in the antrum. Okay. From the duodenal bulb or D1, your landmark is the portal vein, from where you can go and see the head of the pancreas, the common bile duct, pancreatic duct and the gallbladder. For the second part of the duodenum, which overall has lesser utility than the stomach and the duodenal bulb, your landmark is the aorta and the mesenteric vessels. From here again you can see the head of the pancreas, ampullary region, CBD or the common bile duct and the main pancreatic duct. So moving on to the first station, that is the lower end of the esophagus or the stomach. The various structures that you can see include the aorta, that is your landmark, then the left lobe of the liver, the celiac trunk and the SMA arising out of the aorta, the splenic artery and vein, the portal vein confluence, that is the SMV and the splenic vein converging to form the portal vein, and you can see the common bile duct which is seen below the portal vein. So it will be difficult to understand, but to give you some sort of orientation, we introduce the scope from the mouth into the esophagus, then at the lower end of the esophagus or the stomach, we rotate the scope and we reach the aorta. This is the crus of the diaphragm, this is the aorta. As you push the scope a little more inwards, this is the aorta that can be seen, and the first vessel that comes out of the aorta is the celiac artery. The second vessel that comes out is the superior mesenteric artery. So you can always use Doppler flow, which will help in confirming these are the vascular structures, but once you're used to it, it's quite obvious. You can frequently see a third vessel arising from the aorta, which is the inferior mesenteric artery. So you begin here, you see the crus of the diaphragm, the aorta, then you push a little downwards, where you can see the celiac artery and the SMA. After that, if you push the scope a little further, that is this number 3, then you can visualize the body of the pancreas, the pancreatic duct which is in the body, and the splenic vein and the splenic artery. Then if you rotate the scope a bit to the left or in anti-clockwise direction, you can see the portal vein and the superior mesenteric vein. So again, I'll just go through the gastric station or the stomach station or the lower end of the esophagus via the US stepwise. So this is where the esophagus is located cross-sectionally. So you introduce the scope from the mouth, you go through the esophagus, you reach the lower part of the esophagus of the proximal stomach, and this is where your scope is. And your rays are basically moving forwards. So this is what you're seeing. So when you introduce your scope, what you're basically seeing is the left lobe of the liver, which is right in front of you. So this is the US image, this is the left lobe of the liver, and in the middle, this is the left hepatic vein. So then in US, what we are doing is we reach one region and then we rotate. We rotate the scope. So this is what we are going to do. This is the liver where we are currently. Then we will slowly rotate. So once we rotate, we'll go more towards the porta, and then we'll reach the IVC, and then we'll reach the aorta. So apart from rotating, you also push and pull, so you get different regions. So here you have the aorta. Say if I push downwards, then I'll get the origin of the celiac and the SMA. If I'll go a little more downwards, then I'll reach the pancreatic body. Then if I rotate more at that level, on this side I'll get the left kidney and the spleen. So this is how we are going to proceed with the IUS. So right now we've just inserted the scope. Here you can see the left lobe of the liver, the left hepatic vein. Now we have rotated the scope. So what we have actually done is we've gone from here to reach the aorta. So it is a what you call 180-degree rotation that we have performed. So here you reach the aorta, and at the stomach region or the G junction, the aorta is what we consider the landmark. So if we get lost during rotation, we again come back to the aorta and again start again. So here you can see the aorta, And the first branch that is originating from the aorta is the celiac artery, and this is the superior mesenteric artery. So this is again another diagrammatic representation of a similar image. This is the aorta, the first vessel, that is the celiac artery. This is the superior mesenteric artery. So during EUS or endoscopic ultrasound, what we do is we trace structures. So what I would normally do is I would catch this celiac artery and I would follow it. So then you would see it divide into the three branches. The left gastric, which would go here, the hepatic or the common hepatic artery, which should go slightly here, and the splenic artery, which will continue this way. So it has gone this way, but at this section you can only see a cross-sectional image of the splenic artery, and this is the splenic vein, this is the pancreatic body. So this is a diagrammatic representation of the similar structures. So this is where we are. This is our base camp or the landmark, that is the aorta. If I will rotate clockwise or to the right, I will move towards the spleen. If I will rotate counterclockwise, I will go towards the porta, that is the portal vein, SMV, splenic vein, and the common bile duct. So it depends on how I rotate is what the structure is, which structure I will visualize. So after I have seen the aorta and the celiac artery, what I'll do is I'll push the scope a little downwards and I will rotate it slightly in a clockwise direction. So this is where we were. I've rotated slightly clockwise. So here you can see the pancreatic body, the splenic artery, and the splenic vein. Moving on, I will rotate the scope more to the right or more in a clockwise direction. This is where I'll reach the distal body or the tail region of the pancreas, where you can here see the left kidney. I don't know if you all can appreciate, but this is the kidney, this is the pancreas. Okay, and as I rotate more, I will reach the spleen. Okay. So basically we have started from the aorta, we've pushed and we've gone rightwards. We've seen the body of the pancreas. This is the aorta, celiac artery, SMA from where we started. Then we push downwards and rotate clockwise, you reach the pancreatic body. And then you rotate it a bit more and you reach the spleen. Here you can see the pancreatic tail and the spleen. So after you've reached here, you start rotating in the opposite direction to visualize the other side. So again you come back to the pancreatic tail body region and the left kidney. Okay. Then you rotate further anti-clockwise or further to the left and you reach the portal vein confluence. So the superior mesenteric vein and the splenic vein, you can see them uniting here to form the portal vein. So above this part here you have the neck of the pancreas, here is the head of the pancreas. So this is the diagrammatic representation of what we just saw. The superior mesenteric vein and the splenic vein joining to form, this is the confluence, and they join to form the portal vein. Here the common bile duct and the main pancreatic duct are meeting and uniting at the ampulla. So the common bile duct is seen as an anechoic tubular structure below the portal vein. So moving on to the second station, that is D1 or proximal duodenum. Here the home base or the landmark structure is the portal vein. The main structures visualized include the pancreatic head, portal vein, superior mesenteric vein, splenic vein, the main pancreatic duct, and of course the normal pancreatic ecotextures, salt and pepper, which we've already seen from the gastric region. Okay. So again, now we've come to the D1 or the duodenal bulb. So this is, as you know, the duodenal bulb or the duodenum is around the pancreatic head, so it is in close proximity to the pancreatic head, the portal vein and the CBD. So this is where your probe is and this is how you're looking at it. So you can see a part of the CBD and you can see the portal vein confluence here. So this is what you're looking at. So this is the portal vein. it is dividing into the splenic vein and the SMV, or the SMV and splenic vein are forming the portal vein. So then what you do is you rotate the scope towards the left or in a counterclockwise direction. So from here you will be going this towards this side. So what you're doing here is you're going more towards the proximal CBD. So here you can see, here we could just see a part of the distal CBD and the portal vein confluence. Here as we move, we can see the more proximal part of the CBD or the mid CBD, and here this is the portal vein. So as you proceed further, here you can see the proximal CBD, the portal vein, and this is the hepatic artery which is forming the portal triad. Then once we have gone leftwards and visualize the proximal structures, then we turn right and we come downwards to visualize the common bile duct and the pancreatic duct and where they meet. So this part you can see here is the common bile duct. This anechoic structure here is the pancreatic duct, and somewhere here is where they will go and meet at the ampulla. So this is one image depicting all the major structures seen from D1, or the first part of the duodenum. So here you have your common bile duct, which we go leftwards, we'll see the proximal common bile duct. This is the portal vein. Here you can see the splenic vein and superior mesenteric vein forming the confluence. And this is the pancreatic head, where the CBD and from this side the PD will come and they'll meet to form the ampulla. So moving on to the last part of the US, or second part of the duodenum. So the home base here again is the abdominal aorta, and we mainly visualize structures from the second part of the duodenum to look at the ampulla or the periampullary region, where the common bile duct and the main pancreatic duct meet. So this is what you're looking at. Basically your scope enters the second part of the duodenum, and as I've explained to you all during gastroscopy, the major papilla is present on the medial wall of the second part of the duodenum. So that is where your US scope goes in the second part. Here you can see the common bile duct and the pancreatic duct. Okay, they are in the pancreatic head. So they are converging here, and here what you can see is water. This is the lumen. So this is your ampulla, or the major papilla, where the common bile duct and the main pancreatic duct are meeting and are going to open here. Okay, so this is what we basically visualize from the second part of the duodenum. So this is a video of a US. So this is the clockwise and the anti-clockwise rotation that I have been talking about. As you move to the left, it is anti-clockwise, and if you go towards the right, it is clockwise rotation. Moving on to the first region, that is the G junction on the upper part of the stomach. As you put the scope, I said you can see the left lobe of the liver and the left hepatic vein. As you turn rightwards, you can see the umbilical part of the left portal vein, the ligamentum teres and the ligamentum venosum with the middle hepatic vein. Now I will turn further rightwards, going towards the aorta. So first you will cross the IVC. Then as you turn further right to 180 degrees, you will reach the aorta, which is your landmark or your base camp. This is the Doppler showing it as vascular. From the aorta, you see the origin of the celiac and the SMA, as I've already shown you. Then you push the scope downwards at a lower level, and there you will see the pancreatic body with the splenic vessels. Now as you are rotating the scope clockwise or to the right, you are moving from the pancreatic body towards the spleen. So first you will see we are going in a clockwise manner. So first you will see the left kidney. After the left kidney, when you do a further clockwise rotation, you will see the spleen. So this is the pancreatic tail, and this is the splenic hilum with the spleen. Then again you go in a reverse direction, in your anti-clockwise direction. You come back to the pancreatic tail and the left kidney. Then you reach the pancreatic body. And as you rotate anti-clockwise further, you come back to the portal vein. So this is your splenic vein, your SMV, and they're uniting to form the portal vein. This is the part of the pancreas, the neck of the pancreas, and here you have the head of the pancreas. So this is the SMV. If you rotate, you can see the SMA. And below the SMV, what you see is the head region of the pancreas. Below the portal vein, this anechoic tubular structure that you see is the common bile duct. Okay, thank you.
Anybody has any questions from here? Thank you, Dr. Samit, for this beautiful, lucid, and a very, I would say, explanatory presentation, which I think even the UG students have understood it very well, because you went in a very methodical way. And it was insightful for us also, because though we teach anatomy, but looking at anatomy through a scope is quite different. So I think it has helped us all. And we would like to appreciate, Hey.
Are you giving some anesthesia during gastroscopy or colonoscopy? That is my question.
So, ideally they are done under sedation, that is TIVA, this total intravenous anesthesia. You generally use a combination of propofol and midazolam, but it depends center to center and region to region. The practices are different. So here at Nair, we are doing say around 30 to 40 gastroscopies every day. So it is difficult to sedate every patient. So we tell the patients that we are going to perform an unsedated scopy. Those who are ready, it can be done without sedation. That is a simple gastroscopy. But again, ideally, the international practice is to do it with propofol and midazolam. So if you'll see in even in Bombay in private practice, 90%, 9 out of 10 gastroscopies are done using midazolam and propofol. But if you'll go again to peripheries where say the anesthesia backup is not that good, then a simple gastroscopy can be done without sedation. Then moving on to a colonoscopy takes longer and is more painful. So there it is more necessary to give sedation. But again, there are patients, people, centers who can do it without sedation, but it is a painful procedure. For EUS, it again would be advisable to use sedation. So overall, yes, total intravenous anesthesia is required for almost all of the scopies. Thank you.
Dr. Samit, stay here. We would like to present you with a certificate and a token of appreciation from our department. One second. So we move on to our next topic, and our next speaker is Dr. Ashwin Lavande, who is a radiologist at Viva Ultrasound Clinic and at Sir Adrian Reliance Foundation Hospital, Mumbai. And he is specialized in and is recognized as an expert in musculoskeletal ultrasound and guided interventions. He has been the president of IFUMB 23-24 and a counselor from 22-24 at the Asian Federation of Societies for Ultrasound in Medicine and Biology. He's an eminent invited speaker for conducting workshops and taking lectures at various national and international conferences. And Dr. Ashwin shall now take us on a guided journey on ultrasound anatomy of musculoskeletal system, the Google map prior to surgery. And Dr. Ashwin is joining us online. So welcome, Dr. Ashwin. A very good morning to you. And over to you, sir. Yes, sir. Over to you, sir.
Yeah, just try to share the screen now.
Nagraj.
Can you hear me first of all?
You all can hear? No, you are hearing it like that. So, other students also? Yes, we can hear you, sir.
Can somebody help me out with this thing? Sharing the screen? Yeah. Is my thing getting spread now? Wait, no, that's screen.
Now you
I've
can-
shared.
Yes, sir.
And
Sir, you can do it now. You've been made the co-host, so you can share the screen now.
I'm using a Mac here, so there are three options when I put on that. Allow to share window, allow to share screen. So should I click on share screen?
Screen, sir. Screen.
Now you can start the PPT.
1 second. Can you see now?
Yes.
Yes, sir. We can see.
Perfect. So let's start then.
Yes.
Okay, so after an interesting topic, I saw all the images and videos which Dr. Patel showed, and I was really enjoying them. So beautifully taught the internal part of the gastrointestinal tract and the endoscopic ultrasound. Compliments to him. So next is a completely different system which we use in our day-to-day life, and we have so many problems arising from it. And next session will be on how ultrasound helps us in detecting various musculoskeletal pathologies, and how a surgeon is able to use ultrasound as a roadmap for planning the surgery and actually doing the surgery. So the most important thing which any radiologist needs to know before doing a sonography or any particular imaging is anatomy. So whenever we are doing a musculoskeletal ultrasound, a particular body part has to be scanned. You should know how to scan it, and the most important thing before scanning, you should know what you are scanning, the structures, the relationships of various blood vessels, neurovascular bundles, muscles, tendons, where they originate, where they insert. These are the probes which we regularly use. For musculoskeletal ultrasound, we use linear array probes. So these are linear probes which are basically flat probes. They are high frequency probes going from 5 to 14 megahertz or from 5 to 20 megahertz. So this is used for a bigger part, this is used for a smaller part, and for small fingers with an abduction deformity, we can use these probes. So typically these probes have a footprint through which there is a small flat piezoelectric crystal which makes ultrasound waves. When it is pulsed with electric current, the ultrasound waves go, the echoes return back, and then you get an ultrasound image on the screen. So every different body tissue has a different echo signature, and depending upon that, we are able to visualize those structures. So tendons appear differently, muscles appear differently, nerves, blood vessels, bone appears differently. So now the first structure which we are showing you is how a tendon appears on sonography. For example, we are scanning the Achilles tendon here. This is the calcaneum, that's the entire Achilles tendon, which is seen as a thick band of tissue with linear tendon fibrils. So that's the tendoachilles, that's the cavus fat band, and this is how a muscle of the flexor hallucis longus looks with the tendon forming inside. When you do plantar flexion, dorsiflexion, you're able to appreciate how the muscle tendon junction moves. So that's the soleus muscle inserting on the tendo-Achilles. This is in the short axis. You see the tendo-Achilles going in the calcaneum. Again, if you see, that's the tendon, fat, FHL muscle, FHL tendon, soleus muscle inserting on the tendo-Achilles, and then you do plantar flexion, dorsiflexion to see the structures. So, important thing and the hallmark of sonography is like any other means apart from all other imaging modalities, we are able to do a dynamic evaluation and tell you whether that structure is moving properly or no, and differentiate a partial from a full thickness tear, or see whether something has stuck, something is getting impinged by any particular structure. So that is the hallmark of sonography. How does a muscle appear on sonography? This is how the muscle in the forearm appears, that's the brachioradialis, and this is the supinator, that's the proximal radius, which you can appreciate. TS is transverse, and this is in the long axis. So muscle fibers typically appear darker as compared to the muscle. These are the intervening intermuscular septae, or the perimysium, which you can call it, and these are the muscle fiber bundles. So this is the perimysium, that's the epimysium, and these are the muscle fascicles, which are nothing but bundles of muscle fibers. When you tell a person to move, contract, this is in the short axis. And this was earlier in the long axis. Then when you tell the person before contracting, you can see that's how the muscle appears in transverse. And as you go from proximal to distal, you will see the tendon, which is an echogenic portion forming within the muscle. So that's the muscle tendon effect. And as you go distally, you can see the tendon forming within the muscle. Then you tell the patient to contract, and you can see the nice movement of the muscle and the tendon. So this is when a person comes with flexion deformities. The surgeon wants us to test for the quality of the muscle, see if there is any fibrosis, see if there is any fixed length phenomenon because of fibrosis, and see the contractility of the muscle fibers, and see if the muscle tendon junction is moving properly or not. Then this is along the dorsal aspect of the wrist, where you see the radiocarpal joint, the intercarpal joint, and the carpometacarpal joint. So these are the joint recesses. Remember, in the bone, the ultrasound beam does not penetrate. It is reflected from the bony surface. So that's why we see only bony cortex, which is incident to the ultrasound beam, and remaining portion is all posterior shadowing, which has no information. This is the joint recess, that's the joint recess, and that's the extensor tendon on top of the dorsal wrist recess. So if there is any synovitis in rheumatoid arthritis or any kind of arthritis, you will be able to see inflammatory synovium in these recesses. That's the rotator cuff, which you can appreciate here in the short axis. That's the supraspinatus, the deltoid muscle on top, and that's the subcutaneous tissue plane. So if you appreciate here, this is the bone which is incident. That's the articular cartilage, which is darker. That's the rotator cuff, subdeltoid bursa, and that's the deltoid muscle. So this is how we see the muscle tendon difference in echo pattern. Every tissue has a different echo signature. And then you do a dynamic evaluations to test for the tendon movements, if it's getting stuck, if it's torn, and that's how the joint of the finger is seen. That's the metacarpal head, articular cartilage, that's the fibrocartilaginous polar plate, and that's the base of the proximal phalanx. This is the elbow joint, where you see the brachialis, pronator teres, anterior to the radiocapitular joint, the lumbar-ulnar joint, and that's the dorsal ankle recess. That's the joint recess, small joint recess of the finger where you can appreciate some effusion there, and that's the tendon apparatus, flexors. How to see for ligaments? So first of all, again, everything boils down back to anatomy. If somebody tells me or asks me to see anterior talofibular ligament, I should know from what to what it attaches. So it's coming from the fibula and going towards the talus. It has a particular line of course which I am supposed to know. If I keep the probe in this fashion, I won't be able to see it. I have to keep the probe where this particular band is there, and then you can see this thick band-like ligament, and then I do a dynamic evaluation like this to stretch the ligament and see for its integrity. So I'm stretching it and seeing that it's nicely intact and well maintained, and you can see the nice echogenic or bright fibers. Whenever we talk about ultrasound, hypoechoic means dark, echogenic means bright, hyperechoic means bright. This is hyperechoic, that is the bone surface. This is isoechoic, that is the subcutaneous tissue plane, and this is the ligament which is again echogenic, but it is less brighter as compared to the bony cortex. Then this is the testing for the calcaneofibular ligament. That's the peroneal tendons, and underneath that you have the calcaneofibular ligament. So this ligament is only seen when you do a dorsiflexion maneuver, which I am doing here, and testing for its integrity. This you cannot do on an MRI evaluation because it's static. Ultrasound helps in dynamic evaluation of the ligaments, muscles, tendons, and hence you're able to appreciate the functionality and structure of the structures better. Ultrasound has better spatial resolution as compared to MRI, plus the dynamic capability helps us in testing these structures. Then we come to the nerves. So nerves typically go along the intermuscular fat planes. For example, this is the median nerve in the forearm. That's the flexor digitorum superficialis and profundus muscles, and the same nerve I have elongated. So these are multiple black dots which you can appreciate, which are nothing but nerve fascicles. So each nerve fascicle is bounded by a perineurium, and the entire nerve is covered by the epineurium. So these black dots elongate, and these are the nerve fascicles which we can appreciate on sonography. So again, ultrasound gives, with the help of ultrasound, you can study the internal architecture of the nerve and see for any break in the fascicles, thickening of the fascicles, entrapment of the nerves, and inflammation and infective pathologies. Let's see how a peripheral nerve. See, now that's the median nerve at the wrist, and see, this is the transverse now, or in the short axis, and you can see the nerve going proximally between the FTS and the FTP muscles. That's the nerve where my arrow is, and as you come distally, you can elongate and make it in the long axis. That's the nerve. And when you see it in the long axis, if this is the nerve, this is the FTS muscle, FTP muscle, this is the pronator quadratus muscle in the short axis. And when you do flexion, extension of the fingers, you can see the nerve stationary there, and the FTS and the FTP are moving. And that's the pronator quadratus which is not contracting, which is this one. So this is how we see various structures on sonography. The nerve, I'm just reaching the video to show you the structures. This is the nerve, you can see the fascicles. That's the FTS muscle. That's the distal FCR tendon. This is the FTP muscle, and the underlying muscle is the pronator quadratus there. Now we directly go to the carpal tunnel, where we study the normal anatomy first, because I want to show you certain pathologies. So that's the median nerve in the short axis. This is the distal FCR tendon. That's the palmaris longus. This whole bulk is the flexor digitorum superficialis muscle. This is the pronator quadratus communicating the radius with the ulna, and that's the FTP muscle. These are the small tendons forming within the FBS muscle. This is the radial artery on the lateral aspect, and these are the radial veins. And when you play it, you can actually see the median nerve becoming superficial. And as it enters the carpal tunnel, you can see the pisiform bone on the medial aspect. That's the ulnar artery, ulnar nerve in the Guyon's canal, bounded by inferiorly by the flexor retinaculum. This is the median nerve as it just enters the carpal tunnel. That's the flexor retinaculum on top of it, and this is the tubercle of scaphoid on top of which the flexor carpi radialis muscle is kept. And this is the floor of the carpal tunnel, which is formed by the polar wrist recess. So as you go distally, you can see that the median nerve is going through the carpal tunnel. You are able to see the nerve very well. It's darker as compared to the surrounding tendons. So if you consider this as the carpal tunnel, this is the flexor pollicis longus tendon, and these are all the 4 tendons of flexor digitorum superficialis, and these are the tendons of flexor digitorum profundus. You go distally and you see the nerve coming out of the tunnel. So before it comes out of the tunnel here, if I go a little proximal, you will see another bony landmark, that is the distal boundary of the carpal tunnel. So this is the hook of Hamate, and this is the tubercle of trapezium, where the distal attachment of the flexor retinaculum is there, and that's the ulnar artery forming the superficial palmar arch distally. So as you go distally, you see the nerve dividing into the common digital nerves as it comes out of the tunnel, and these are the tendons going to the respective fingers along the metacarpal shafts. If I magnify it a little more at the carpal tunnel, what you see here is that's the nerve, and this small dot which it comes out is the palmar-cutaneous branch of the median nerve, which is so important when you do carpal tunnel surgeries. So if you can appreciate here, that's the median nerve with its fascicles. This particular dot is the palmar-cutaneous branch, which concentrate on it. As I take my video behind slowly, you're able to see that small dot coming and merging with the median nerve there. So that's my palmar-cutaneous. And as I take my video ahead, you can see the nerve palmar-cutaneous going out of the carpal tunnel, over the carpal tunnel, and then going into the soft tissues. So that's the nerve going into the carpal tunnel, and that's the palmar-cutaneous branch going on top of the tunnel, and that's the distal FCR tendon. So this is how we can guide a surgeon that yes, when you are doing a carpal tunnel release, this particular nerve is so many millimeters away from the median nerve, because they typically take an incision on the radial aspect lateral to the median nerve when the carpal tunnel release happens. After that, we see the nerve in the long axis as it enters the tunnel. So these are the nerve fascicles, these are the flexors, and that's the distal radius. So you see here, that's the nerve entering the carpal tunnel, showing a normal echo pattern. It's not showing any compression, and that's the underlying flexors which appear brighter and echogenic as compared to the nerve. So when you have such an appearance of the nerve, you know that the nerve is not getting compressed in the tunnel. But yes, these are all subjective appearances. We have certain objective criteria to say that yes, the nerve is compressed or it's not compressed. So that's why what we do is we measure the nerve cross-sectional area in the distal forearm proximal to the pronator quadratus, which is around 12 millimeters square here. Then you go a little distal at the level of the wrist joint. See my ultrasound probe marker. Here the nerve cross-sectional area is 16 millimeters square. So 12 has become 16, which is fine. Around 5 to 6 or 7 millimeters square increase is acceptable, because the nerve slightly flattens as it goes through the tunnel or any osteofibrous tunnel. So this is my FPL, that's the median nerve, and these are all the flexors. That's the distal FCR tendon which will go out of the carpal tunnel. And at the carpal tunnel, you can see the nerve nicely entering the tunnel. And then what we do is we measure the nerve flattening ratio or the nerve compression ratio within the carpal tunnel, especially in its mid portion between the pisiform and the scaphoid and the hook of Hamate. So you divide the transverse diameter of the nerve by the AP diameter and you get a ratio which should be less than 3.5. If the transverse diameter increases, AP diameter decreases, that means the nerve is getting compressed, and when the nerve gets compressed, this particular cross-sectional area proximal to the tunnel will increase as compared to the cross-sectional area in the distal forearm, which will remain the same. So if this is 10 or 11 here, this instead of 16 will become around 20, 22, and that's the time you know that there is compression on the nerve and the patient will get sensory disturbance in the median nerve distribution. So typically, when the carpal tunnel syndrome happens, your sensory symptoms start first, and then if it's neglected for many years, then motor symptoms start, and typically the thenar muscles have to go wasting. So that's how the nerve is seen throughout the tunnel. You can see the nice cables or the fascicles of the nerve lying on top of the flexors, and that's the flexor retinaculum anterior to the median nerve. Let's see some normal variations. Now that's the median nerve. Normally you see the nerve as a single trunk, and you see some artery next to it. So let's see what is this. This is the short axis, that's the FDS, FDP. And as you come distally from the distal forearm into the carpal tunnel, you see that the nerve is dividing into two trunks. So this is the bifid median nerve with a persistent median artery which is patent as it enters the carpal tunnel. So this is a variation of normal. Again, I'll show you. So it's a single trunk in the distal forearm, and then proximal to the tunnel, it divides into two. And these are the flexors within the tunnel. So this is still normal. There is no compression of the nerve. Now what happens when there is a compression of the nerve in the carpal tunnel? The proximal nerve becomes edematous. Why does it become edematous? Because the fascicles getting compressed here, the proximal fascicles and sometimes the distal fascicles, they get enlarged because of the fascicular edema, and that's the time when you see nerve compression happening within the tunnel and nerve enlargement happening proximal to the tunnel. So this is the nerve enlargement which is at the level of the wrist and the distal forearm. That's the enlarged portion of the nerve in the wrist, and this is the compression within the carpal tunnel. Again, I'll show you. This is the nerve compression, and that's the enlargement. This is the distal forearm. So again, now when we measure the diameters, this is in the distal forearm, which is 6. Now at the level of the wrist, see how much it has become. It has become 32 millimeters square. So it has almost become around 5 times the normal size of the nerve, and that's because the nerve is compressed here. You see the amount of flattening of the nerve, and the ratio, which is around 3.5, has become 6.6. So this is the nerve appearance if there is no compression distally, and this is the edema of the fascicles when there is compression distally, which is why the nerve does not show a cable-like appearance. And that's how the nerve gets compressed. You see there, that's the compression of the nerve which I showed in the mid-carpal tunnel, and that's the enlargement of the nerve proximal to the tunnel. So when a surgeon does a carpal tunnel release, he knows that he has to, where the compression is on sonography, the amount of compression on sonography, and then the quality of the flexor retinaculum, and if there is anything within the tunnel. See, the whole thing is, surgeons most of the times, you know, the carpal tunnel is a clinical diagnosis. They see the, you have the EMG report with you. So yes, if there is pure, only carpal tunnel symptoms, patient is able to flex the fingers nicely, there is no flexion restriction, there is no other joint pathology there. It's like a pure carpal tunnel syndrome which is diagnosed on clinical evaluation and EMG, and the surgeon does a surgery. But nowadays what happens is, in spite of a carpal tunnel release, sometimes the patient doesn't feel better. or the symptoms don't go away, and that's the time when you have to examine the patient clinically earlier properly. So if the patient is not able to flex the fingers completely, and if you see some swellings along the wrist, little generalized, little enlargement of fullness along the volar aspect of the wrist, it calls for an ultrasound evaluation. Because on ultrasound, apart from the degree of compression, we are able to tell you that there is no synovitis in the carpal tunnel, there is no space occupying lesion in the carpal tunnel. So with this, what happens is, you're able to tell the surgeon that yes, there is something there. So along with the carpal tunnel release, you'll also have to do a synovectomy. Because if you do a carpal tunnel release without any imaging and the synovium you find as a surprise, then the patient won't get any relief and the flexion of the fingers won't happen because it's encasing the flexors. So that's why an ultrasound is important. Sometimes you see changes of arthritis in the joint traces when you're doing a carpal tunnel ultrasound. That's an additional information which you can give a surgeon. Now this patient is again have sensory symptoms in the median nerve distribution in the left hand and has come for a carpal tunnel evaluation to see the amount of compression. Because what happens is an EMG and a nerve conduction study will give you a functional information about the degree of compression, mild, moderate, severe, but you don't know the physical compression because sometimes the EMG and the clinical findings are not matching. Sometimes clinically the surgeon feels it's a mild symptoms, EMG will give a moderate to severe report, but then you need the exact amount of compression. Even if the EMG says that it's a moderate to severe symptoms, moderate to severe conduction delay in the median nerve, ultrasound can show the degree of compression, whether it's mild or whether it's severe. So depending upon that, you can tell the patient to do neurodynamic stretching exercises or plan for a carpal tunnel release. Now you see this patient came with carpal tunnel symptoms, and you see that the median nerve proximal to the wrist is showing something within it. This is in the long axis. It's actually showing a lump within its substance. Let's see it again. This is the lump. This is the entire nerve in the short axis. Because it's the left wrist, these are the radial fascicles and these are the ulnar fascicles. So as you go distally, I'm going down, you can see there is a nice, well-defined solid mass involving the ulnar fascicles of the nerve, and the radial fascicles of the nerve are kind of safe. You go further distally, you see that the radial fascicles are getting spread out over the mass and the ulnar fascicles are kind of getting stretched here. You go further distally, and this is the place where the nerve enters the carpal tunnel, but the mass does not go within the carpal tunnel. So this is the nerve entry into the carpal tunnel, and then I am coming proximally in the distal forearm again. Then you see the mass disappearing and the nerve fascicles seen very nicely. And then this is in the long axis. So in the short axis you can see the fascicles very well, and that's the fascicles of the nerve, the mass. So after doing this imaging, we gave the dimensions of the mass and gave a diagram to the surgeon. This was showing some vascularity. Then this is the picture. This is the mass. The ulnar fascicles are kind of getting stretched over the mass, and the radial fascicles are safe. So that's why the symptoms. So there was no carpal median nerve compression within the tunnel, but it was a median nerve tumor. And these are the intraoptics, where you see the lesion properly, and then it's further dissected. And then as you see with further dissection, you can see it arising from a solitary fascicle, which is seen here. So the rest of the median nerve fascicles were absolutely intact and normal, but this single fascicle was showing this particular schwannoma. So this was completely excised and the fascicle was repaired. So this was the end result, and the tumor was excised. It was a benign schwannoma. So with the help of ultrasound, we can actually, apart from the gross anatomy, we can actually see the internal anatomy of any particular structure and give a roadmap to the surgeon. Next is painless diffuse swelling in the distal forearm and wrist, volar aspect. So this was a young middle-aged lady with this lump, and she was finding it a little discomforting while flexing the finger. Now what do we see here when we keep the probe transverse in the distal forearm? So what you see here is, this is a well-defined, solid lump. Another important thing about ultrasound is, it's the best imaging modality to tell you whether it's solid or cystic. Cystic will appear complete dark like this, like blank thing here, screen, and solid will appear like this, which is organized echoes. The echoes are not mobile. So this is located on top of the pronator quadratus, which is connecting the radius and the ulna. It is lifting up all the flexor digitorum profundus and superficialis tendons. It is kind of going in the space between the two FDS tendons. So the FPL is on one side, the median nerve is on one side, the ulnar artery and the ulnar nerve are on the anterior and medial aspect, and that's the distal FCU muscle tendon junction. Long axis, that's the lesion, 5 centimeters long, going into the carpal tunnel there. So we don't know whether it's actually going into the carpal tunnel, we'll have to go and see. So you can see a small peak-like projection going into the carpal tunnel. So that's the area of origin. The flexor synovium of the ulnar bursa within the carpal tunnel. And then you actually image the carpal tunnel where you see that the median nerve, digitorum superficialis and digitorum profundus tendons are nicely sitting there. That's the volar carpal recess, the radius, the proximal carpal row and the distal carpal row, and there is no mass here. Then you do a dynamic and flex the fingers and see what's the quality of the mass. So it's a solid mass, it's a soft mass, it's compressible, and it is separate from the tendons. It's in that fat plane, not infiltrating the tendons, but it is lifting up the tendons and kind of moving to and fro, just trying to enter the carpal tunnel but not really present there. See the short axis. This is the carpal tunnel where you see the scaphoid. This is the tuberculum trapezium and the hook of Hamate. That's the flexor retinaculum. That's the median nerve. You just see the flexors, you don't see the mass. Now from here you go proximally, and here you see the mass coming from the proximal carpal tunnel and going proximally into the distal forearm. That's the mass. So what we see from here is, I again take it here, and now I slowly scroll it proximally. As I scroll it proximally, what you appreciate here is, this is the origin of the mass. That's the median nerve. This is the scaphoid, that's the pisiform which will come here now. And as you go proximally, you see the portion of the mass coming from the proximal carpal tunnel, that's the median nerve. You go further proximally, and what you appreciate is FDS, FD3, mass, pronator quadratus. Go further proximally, you see that the mass is located, the ulnar nerve, this is the ulnar nerve, and the ulnar artery is located anterior to the mass, not involved. And you go on the radial side and you see this is the median nerve, that's the flexor pollicis longus tendon. So they are kind of away. Okay, so that's, I'm doing the short axis view and the flexion extension of the fingers, and you can see the mass nicely moving, the tendons are not involved. It's showing significant vascularity, but it's not a vascular malformation because there are no vascular spaces or phlebolith. So this is the picture given to me by given by me to the surgeon, kind of a roadmap. So what this gives the information is, that this is the mass which is well defined, well encapsulated, has a nice fan plane located between the pronator quadratus and the flexors. The under neurovascular bundle and the median nerve are separate, and this is in the long axis. The peak or the organ of origin is the synovium of the carpal tunnel, that's the ulnar bursa, which houses the long finger flexors and the spear tendon. So that's the dissection now, which is happening. You can see that's the peak going into the carpal tunnel. That's the peak which was there in the carpal tunnel, and the whole mass is kind of enucleated as you kind of separate the FDS muscle mass, and that's the whole mass which came out very smoothly, and it was pretty soft, but it turned out to be a giant cell tumor. So I had given a differential of a giant cell tumor and a synovial, benign synovial tumor, because giant cell tumors are usually hard masses, and this was kind of a soft one which was there in the at the wrist and the proximal tunnel level. Another case, a middle-aged lady with painless gradually increasing lump in the left palm, no motor sensitives. You see a lump here, and you also see a lump here. Now we have to image on the volar and the dorsal aspects of the palm and see what is happening. There's this mass which is there in the thenar eminence, extending underneath the flexor tendons and the neurovascular bundles. So this is the flexor tendons to the fingers somewhere in the mid palm level, and these are the metacarpals located here, and that's the echogenic homogeneous mass which is so classical of a lipoma. What you see is lifting of the neurovascular bundles going to the ulnar side of the thumb and the radial side of the index finger. So these are the digital nerves which we can appreciate on sonography. On the dorsal aspect, when you view through the first web space, you're seeing that it is kind of splitting both heads of the adductor pollicis muscle and lifting up the first dorsal interosseous. You keep the probe in the third intermetacarpal space dorsally, and you see that the third dorsal interosseous muscle is getting lifted up, and that's the same mass which is coming from the dorsal aspect and coming between the third and the fourth metacarpals. Otherwise, this is the normal intermetacarpal space which houses the dorsal interosseous located between the second and the third metacarpals. So this was the diagram given. So this was the first image of the mass which you saw where the digital nerves to the thumb and the index finger are going. Then these are the flexor tendons and the neurovascular bundles which are on top of the mass. That same mass is seen going, splitting the dorsal interosseous from the metacarpal curve and lifting up the extensor tendons to the middle and the ring fingers. So that's what the diagnosis given and the relationship. So when you give a relationship-oriented diagram and the description to the surgeon, it acts like a good roadmap, and then you don't need any particular further investigation like an MRI. So that was the enucleation. We also tell the surgeon the route from where he has to go, whether it's the volar aspect or the dorsal aspect, and this is the complete enucleation of the lipoma through one particular incision. Now let's go and see the complications of various orthopedic hardware. This was a 40-year-old dog with fracture at the elbow, fixed with plates and wires, has developed an ulnar claw. What do you see? In the upper forearm, what you see is there is a significant compression, short segment compression or kink of the ulnar nerve in the proximal cubital tunnel. When you see properly, you actually see a metallic wire which is kind of compressing the nerve at this location. And when you do a movie, scan the nerve in the short axis and it comes into the tunnel, you see it is getting compressed by this nerve. Can you see this compressed by this wire? So that's the wire which is compressing the nerve at this level. If I take it proximally, you see the wire in the long axis. You can see that's the wire in the long axis compressing. So this is the wire in the long axis and the nerve in the short axis. Now the nerve is in the long axis and the wire is in the short axis. So there it is compressing. So then came to know that why this doctor had developed an underclock after an elbow fracture repair surgery. And we saw on the X-ray which is the culprit which is there. So that was the wire which was kind of pinching the nerve and giving rise to the underclock. So the treatment was to just excise this wire and let the nerve breathe and recover. So that was the diagram given to the surgeon. Because everything was nicely done. The fractures and all were nicely repaired, they were intact. That was the intramedullary aerial ulna, that was one plate, the second plate. So that was the wire which was excised, and that really helped the patient in recovery. Another patient with a shoulder plasty done with good recovery, that is the first surgery. Then implant loosening happened, which was later tightened with wires along the upper shaft of humerus. Now, after the second surgery, the patient developed this wrist problem. You can see the scar of the surgeries and the wrist problem. And then the EMG was done, which showed a severe axonal type of radial sensory motor neuropathy around distal to the triceps branch. Now, remember, triceps branch of the radial nerve is given significantly higher up below the axilla, and this is the radial nerve involvement which is below that. So somewhere from the level of the proximal to the spiral groove up to the lower arm, we have to trace the radial nerve. So when we traced the radial nerve, what we saw was the lowermost wire which was used was kind of penetrating the nerve, going through the substance of the nerve in the spiral groove, that is the proximal spiral groove, and kind of giving compression. So if you see, this is the wire which was the culprit. The other two wires were significantly above, because the radial nerve, as it comes down, it goes behind the humerus in the spiral groove and then comes anteriorly like this. So if you see here, that's the spiral groove somewhere, and this is the short axis, that's the shaft of humerus in the mid-arm. And you can see the wire going through the substance of the nerve and kind of compressing. So earlier the ulnar nerve was just compressed. So this is compressed as well as the nerve penetrating, the wire penetrating through the nerve. So that wire was removed and the patient slowly recovered gradually. See, nerve injuries, it takes a significant time to recover. Deformity of the elbow with a childhood malunion. This was a television news reporter, and typically he had a childhood malunion at the upper radius ulna with radial dislocation, and this was her hand. She was not able to extend her hand and extend her fingers properly, and that's why as a presenter she was finding it quite odd and difficult. So the surgeon wanted to know what's the status of her posterior intraosseous nerve. So posterior intraosseous nerve, if you see the normal anatomy, it goes between the two heads of supinator located underneath the brachioradialis muscle. So these are the supinator heads, and that's the posterior intraosseous nerve. What was happening in her case is, because he had an upper radius ulnar fracture, the supinator was fibrotic, the radius head was dislocated, and this was kind of, the fibrotic supinator was kind of impinging and pinching the posterior intraosseous nerve, causing like an entrapment. So that was such a severe entrapment that the proximal nerve was showing enlargement. So it was pin entrapment neuropathy, because of which her extensors were not functioning too well. And you can see the enlarged nerve and the compressed nerve in the fibrotic supinator. So this we are doing pronation, supination, pronation. You can see the radial head nicely moving differently as compared to the ulna there. So dissection was done, and that's the posterior intraosseous nerve which is enlarged. That's the fibrotic supinator, where it's going. Further dissection shows the fibrotic supinator and the enlarged nerve, and that was the picture. told the surgeon that exactly when the nerve was getting compressed in the supinator, and she had a good physiotherapy sessions for 6 to 7 months, and this was the recovery of her wrist and the recovery of her fingers, and that's the scar of surgery which you can appreciate, and this was before the scan. So like this, when there are humerus fractures, we do mapping of the radial nerves for the surgeons. When there is a revision surgery to be done, we map out the radial nerve, we tell them that this is the point marking and this is the location. So before the surgery, they can plan not to touch the nerve. Then for reconstructive surgeons, we give such roadmaps. By scanning them, this takes quite a significant time to go through the distorted anatomy and the fibrotic structures. We have to really put a lot of gel, see for the altered anatomy, fibrotic tissues, move certain structures, and actually then plan the roadmap like this. Then we come to lumps like this, where the surgeon wants to know first of all what this lump is, whether it's what kind of a tumor it is, whether it's a benign malignant or whether it's a lipoma, vascular malformation, giant cell tumors, ganglion cysts, what exactly it is. So this was, I don't have the ultrasound images now, but I'll just show you the picture which I gave to my surgeon. This was in 2018, where this was the lump between the thenar muscles. The opponent's pollicis was on the flexor digitorum brevis was on one side, the adductor pollicis was on one side. The abductor pollicis brevis was not affected, the FPL was here, and that was the mass through which the digital nerves to the thumb were going, and that's the nerve to the index finger. That is this one which was going on top. Next, painless hard lump. This was a doctor who had a painless hard lump in the thumb here and was getting some discomfort because the neurovascular bundle was getting irritated there. And he was a surgeon, so it was giving him some problems. So this is the short axis of the thumb where you see the proximal phalanx and the FPL tendon. And that's the radial digital nerve and the artery. As you go distally, this is the proximal phalanx, and that's the mass. The digital nerve is going on top of the mass, and the artery is going from the side of the mass and supplying this thing. And that's the bony scalloping, which you can appreciate because of the mass on the bone, and the flexor tendon is not involved at all. The nerve, the artery, the mass, involvement of the bone, that was the vascularity by the radial digital artery, the feeders, and this was the diagram given to the surgeon. So basically told him that this was the solid well-defined mass, kind of causing scalloping on the bone. The nerve and the artery were separate, arterial feeders coming to the mass from the radial digital artery. FPL tendency is not involved, and the mass does not involve the NCP or the IP joints. So the radial neurovascular bundle was separated first from the mass. Then the mass was slowly dissected, enucleated. It was a giant cell tumor, and that's the nice clean FPL tendon which is located as you see here. Then we also do scans for congenital anomalies. So in such cases where the fingers may have some mobility or may not have mobility, what first of all information we give is we tell the presence or absence of the flexor tendons, extensor tendons at the level of the wrist and up to the insertion in the finger base. Then we tell them the status of the nerves and the vessels. We trace the vascular tree as they go into the fingers. And then a diagram is given like this where we tell that yes, there are blood vessels on either side of the finger, so separation won't be difficult. It's just separation of the soft tissues. The tendons are present, or if the tendons are not present, some reconstruction is required. And if the blood vessels are not present, then some vascular flaps will be required. So that is the information given. And once you draw the diagram on the particular parts, then post surgery, this is the picture how this particular person has a record, and then this is the function where you step for the movements. So this is how functionality is achieved post reconstruction. So summarizing, ultrasound can give you so much information and even much more than other radiological modalities when you need to see soft tissue structures with dynamic evaluation. But the most important thing is, if you don't know any proper anatomy, if you just try to do a scan without knowing the anatomy, you cannot give all this information. So your anatomy has to be strong. And even today, after 20 years of my practice, if I have any doubt, I will revisit my anatomy on my phone in front of the patient while doing the scan. And so that, anatomy always gets brushed up and you learn so much more nuances of normal variations when you read anatomy. So with the correct equipment and using the right frequency probe, which obviously after using it in various difficult cases, we can give an accurate roadmap to the surgeon so that the surgeon is more comfortable in going in and doesn't have much surprises. And when you give such a roadmap in the form of a diagram, you get return gifts back in the form of intraoperative images. So we come to know what mistakes we have done, whether we have given the correct information, and then we are better prepared when we do a next scan. So doing a specialized ultrasound with the thought process of a surgeon makes the scan so motivating and productive. So I finished with my talk, and I thank you for your patient hearing and thank you for inviting me.
Good afternoon all. I am Dr. Nagaraj Pai, Associate Professor Additional in TN Medical College and Nair Hospital, Mumbai. As the organizing secretary for the webinar, take this opportunity to thank Dr. Ashwin Nawande sir for giving us an insight about ultrasound of musculoskeletal system and telling us how integral the knowledge of anatomy is to your modality and specialty. You literally dissected the limbs with your ultrasound probe. Thank you very much, sir. Thank you very much. Dr. Nimish Kamath sir to deliberate on anatomy, physiology, radioisotope tracers in PET. Dr. Nimish Kamath sir is an eminent speaker, expert in his domain as a senior consultant and associate director radiology CT PET CT at Nanavati Max Super Speciality Hospital. I now invite sir for his session.
Okay, am I audible? Okay. At the outset, I'd like to thank Dr. Nagaraj Pai, Dr. Khambata, Dr. Yuraja, Dr. Vivek, and those names who have missed out from the anatomy department for arranging this conference, as well as inviting me to give a talk on role of PET CT in today's era in clinical applications. I want to first of all give my respect to your ex-HOD, Mr. Shyam Kishore, who apparently has been a role model for the entire department and for the students. Without wasting much time, I'd like to start my topic. We at Nanavati Max started our PET CT department in the year 2010. And the last 15 years have been an overwhelming experience for the utility of PET in today's clinical practice. The credit for introducing radioisotope goes to Mr. Carl Anderson, who in the year 1932 first used positron emitting radionuclides. And this was followed up in the year 1976 by Alf Wolf and Joanna Fowler, who first studied the glucose metabolism using 18-fluorodeoxyglucose. And this was the cornerstone of modern PET imaging. The initial tracers which were used were 15 oxygen, 13 nitrogen and 11 carbon. But since they had short half-lives, they could be transported from the cyclotron facility to the hospital. So today we have robust tracers which have a half-life of almost 120 minutes. Little bit of the hardware and software before we go to the actual clinical applications. The PET is one part of the machine and the other is the CT part. In the PET, we have the detector ring, the scintillating crystals and the photo detectors. Whereas the CT scan component contains the CT scan machine, the computer system and the patient bed. This is how a typical CT scan machine looks. In the front portion is the gantry of the CT scan with a row of detectors. And behind we have the PET detectors. And this is the table or the couch on which the patient lies. The patient is always scanned in the prone position with the hands up towards the head to prevent any artifacts from the upper limb bones on the chest, abdomen and pelvis. Typically we scan the patient from the head to the mid-thigh, but if there are exceptions to this rule where we scan the patient right from the head to the toe, and these exceptions are multiple myeloma, certain tumors which metastasize distal to the elbow and knee, that is breast and lung. We also scan patients who have sarcomas in the limb. We have to complete the entire study. And another exception is melanomas, where you have to do a whole body scan. Coming to the principle of PET-CT, it is important to understand this principle because that's what is the mainstay. When we inject intravenous fluorodeoxyglucose into the body, it is transported inside the cell by a glucose transporter called as GLUT1. Once it enters the cell, it undergoes glycolysis and phosphorylation and gets converted into 18-FDG6-phosphate. Now this gets entrapped within the cell because there is no transporter to take it outside the cell. Now what is 18-FDG6-phosphate? It is nothing but it is a positively charged positron. And within the cell we have what is called as negatively charged electrons. So what do these electrons do? They annihilate the positively charged protons and they produce 2 photons, each of 500 kiloelectron-volt energy. These photons then strike the detectors on the PET, and this is how the patient lies on the table. You can see the scanned, the images are transferred, you get photon energies. This gets transferred by a process called as analog to digital and digital to analog, and we obtain the final images on the computer. The various radio tracers which we use in our clinical practice, 18-FDG is the most common, easily available, cheap. It is used mainly for oncology purposes, infections, inflammations, followed by 18F-PSMA, which is used mainly for staging and staging of prostate cancers. 68 gallium dotatate and dotaNOC isotope used for neuroendocrine tumors. And in the last decade, we have been seeing a lot of patients for neuroimaging in which we use 18-fluorodopa radiotracer. In case of cardiac perfusion, we use 15 oxygen, 13 nitrogen, and 82 rubidium. Rubidium is an expensive radioisotope. Initially, for bone metastasis, we are using 18 fluoride PET, but this has now become obsolete. Like in CT scan, we measure the tissue in the form of Hounsfield units. Like bone has plus 1000, or calcium has plus 1000, air is measured in minus 1000, clear fluid, CSF, in values of 0 to 14 Hounsfield units. you have blood anywhere ranging from 50 to 100, depending on whether it's acute, hyperacute, subacute or chronic. In the same way, we assign SUV max in PET imaging. So what is SUV max? It is the concentration of FDG within a particular cell to the ratio in the entire body. So it is also called as standard uptake value. So loosely it can be compared to ESR. So it has got a lot of prognostic value. Now SUV max is sensitive but not specific because it depends on multiple factors like biological, technical and patient-related factors. So typically when a patient comes to the hospital, of course we do a counseling one day before, we take the history, we look at the serum creatinine level, we see whether the patient is a diabetic or not. If the patient is diabetic, the sugars have to be controlled. So when he walks into the department, we take the weight of the patient. Weight is important because the dosage of radioisotope is given according to the weight. So for every 10 kgs, we give 1 millicurie. So if the patient weighs 70 kgs, we give 7 millicuries. If the patient weighs 100 kgs, we give 10 millicuries. So why is it important? Because if we underdose, then the SUV max changes. It's always important to appropriately weigh the patient and give the appropriate dose. We check the blood sugar levels. Ideally, they should be less than 200 milligram per deciliter. The reason for that is very simple. I had mentioned earlier that the entire principle of FDG PET is on glycolysis. So we have three types of cells. We have the normal cells, which also have a rate of glycolysis. We have cells which are harboring malignant tissue, and we also have cells which are inflammatory. So the rate of glycolysis varies in the cell. Suppose the patient is diabetic, the sugars are uncontrolled. The maximum rate of glycolysis will be in these cells which have high sugar. So instead of your radio tracer going to the malignant cells or to the infectious cells, they get diverted to the cells which have high sugar. So automatically you get a low SUV max. Third is the time of injection to the time the patient is taken on the table. So ideal time is 45 minutes to 1 hour. Suppose if I delay this to more than 1 hour, what happens is I get high values of activity in the bone, the liver, the spine, because these are all sites of extramedullary hematopoiesis. So you have to scan the patient in the proper time. So if you have 5 patients, inject them according to that time so that you can take the patient on the table in the appropriate time. Also, it depends on certain type of tumors. Like signet ring adenocarcinomas have got low SUV max. Certain type of sarcomas have got low SUV max. Whereas CA breast, CA lung, and all other malignancies have got high SUV max. One more thing I want to mention here is that PET-CT can be performed in patients who have a deranged renal profile. In those patients, what we do is we don't inject the contrast for the CT. The radio tracers that are used are all inert, they are non-nephrotoxic, they are non-hepatotoxic. The latest machines which have been installed in the last 1 or 2 years have got a lot of features of software technology, which includes time of flight, digital PET, 3D PET, dynamic and hybrid PET. So what do these do? They reduce the scan time. Today, a PET scan patient requires at least 20 to 30 minutes on the table. And the quality of the images may not be as good as what they are today. Today, a scan, the patient can be scanned in less than 10 minutes from head to toe. So the chances of respiratory movement which can obscure images in the lung or liver is overcome by this technology. Now coming to the common tracers which we are using in our department is fluorodeoxyglucose, followed by PSMA, and third is DOTA-NOC. If you see this, these are coronal images of only the PET image. Everything looks the same, black and white. But it is important for us to understand what is normal before we comment on what is abnormal. So you should know the physiological uptake of radio tracers. In case of fluorodeoxyglucose, if you see, the brain is the most metabolic organ in the body with a high rate of glycolysis. So if you want to study brain lesions, you have to repeat the scan after 2 hours when the physiological activity in the brain decreases. But with the presence of MR, we usually don't follow this. Second organ which is highly metabolic is the myocardium of the heart. In the neck, the physiological uptake can occur in the larynx, it can occur in the subadrenal glands, it can occur in the tonsillar fossa. Now if you see the image on the right, if you see here, there are these areas which are black. It is nothing but brown pad of fat or adipose tissue. Now what is this brown pad of fat? It is used for thermogenesis. It occurs in the pediatric age group. It is seen in thin asthenic individuals. It is also seen in patients who are undergoing chemotherapy and radiation therapy. So this is a physiological uptake for FDG. The radioisotope is typically excreted by the kidneys and the GI tract. Now coming to the PSMA PET scan, the physiological uptake occurs in the salivary glands, all the 3 salivary glands, including the lacrimal gland. It also occurs in the liver and spleen. So that is why certain metastatic lesions from the prostate to the liver and spleen have to be commented upon on the CT and not on the PSMA PET. Physiological absorption can also occur within the small intestine, sympathetic ganglia, the bone marrow and in the testes. Coming to Dotanog, where we use it for neuroendocrine tumors, the physiological uptake occurs within the pituitary gland, the thyroid, the thymus, the liver, spleen and adrenal glands, and again excreted by the kidneys and the GI tract. Physiological uptake can occur within the bone marrow and the muscle, but it is diffuse, not focal. If there is any focal lesion, then it becomes pathological. Coming to the clinical applications of PET-CT, initially it was only used for malignancies, but now the scope has widened. We are using it in patients, neurological patients, especially in epilepsy, dementia, brain tumors, and in movement disorders. Now, this is a interictal scan in a patient who has presented with epilepsy. The reason for doing the PET-CT in this patient is you want to look at the epileptogenic focus. You can see this on your EEG, but the quantification is better seen on the PET, where you can see those areas which are hypo, which are not lighting up compared to what you are seeing in the rest of the brain which is lighting up. Now, we are seeing an increased incidence of Parkinsonism in the Indian population. Initially, it used to be at the age of 70, but we have also now started seeing patients between 50 and 60 years who present with movement disorders. So what do we see? We know that the concentration of dopamine is maximally seen in the caudate nucleus, the dentate nucleus, the red nucleus, the basal ganglia. So this is a typical normal PET-CT where you can see hypermetabolism within the caudate nucleus. This absent coma sign is seen in patients with Parkinsonism. Now, how do you differentiate drug-induced Parkinsonism from true Parkinsonism? We know there are certain drugs which are used for schizophrenia, for psychotic disorders. These can either block the dopamine deposition, or they can block the dopamine receptors, or they can deplete. So we have tablets like Respirin, which can deplete the dopamine within the putamen, and we also have certain medicines which can completely block the dopamine receptors. So how do you differentiate? Classically, in a patient with false Parkinsonism or drug-induced, you can see that the coma sign is maintained within the caudate nucleus, whereas in patients with true Parkinsonism, there is complete depletion of the metabolic activity. We also use PET-MR for differentiating active disease in patients with infection and metastasis. Now, how does it help you? There's something called as morphologic lag. The patient is improving, but you're still seeing lesions on anatomy. So what do you explain to the patient and the relatives? They're very anxious. So what you do is you perform a scan and you look at the activity within. This is an axial T1 weightage contrast image which shows a peripherally enhancing lesion with thick walls. Now, this would have been either called as residual disease. But when you do a PET scan, you see only metabolic activity at the periphery of the lesion, saying that this is responding to treatment. Another patient who had a tuberculum on the brain, periphery enhancing, but when you do what is called as a TSPO, translocator protein specific inflammatory PET, you see that there is no activity. So this is a morphologic lab. Another patient, this is an axial T1 weighted image showing a lot of vasogenic edema. You can see a broad-based lesion which is iso to the brain parenchyma. This hallmark of disproportionate vasogenic edema is specific for metastasis and any malignant intracranial SOL such as glioblastoma multiforme and high-grade gliomas. So on the PET, concurrent PET image, you can see that there is areas of increased metabolic activity. See, we are seeing a lot of cases of dementia. So there is a classification of dementia. Again, to prognosticate, it is very important to know how much brain is depleted of the glucose, because these patients again are going to live long, are going to have a lot of disability. They need rehabilitation. In cases of normal brain, you can see there are hypermetabolic areas throughout, which are maybe symmetrical or asymmetrical. In case of Alzheimer's, which is typically restricted to the temporal and parietal lobes, you will see complete depletion of the metabolic activity. Whereas in case of Pick's disease or frontal lobe dementia, the whole area becomes hypermetabolic. These are color coding, which is internationally used. We also use PET scan in patients who of autism, where they have hypermetabolic areas. Post-treatment, we see whether these areas return back to metabolic activity or not. It is mandatory today in cardiology that any patient who undergoes a CABG, who has a low ejection fraction, to undergo a cardiac PET CT. This is because you want to know whether post-surgery, post-operatively, the patient myocardium is going to remain the same or the myocardium viability is going to increase. So we perform myocardial viability studies, perfusion studies. We also use this in case of myocardial sarcoidosis, where the patient may not be fit for MRI. In case of cardiac tumors and infection, again, MRI is the choice, but there might be a lot of contraindications for MRI, like you may have pacemakers, patient may have metallic implants. So what do we look in a myocardial viability scan? If you see the first image, it shows that using N13 ammonia, the perfusion within the myocardium is maintained both in the perfusion scan as well as in the myocardial viability scan using the fluorodeoxyglucose. In case of irreversible dysfunction, we know that the left ventricle of the heart is supplied by the left antidescending, left circumflex as well as branches from the right coronary artery. Now this patient had in both the phases, that is in the perfusion as well as in the viability studies, did not show any retention or any metabolic activity. Compared to the reversible dysfunction, which you see that in the perfusion image, there is no metabolic activity, whereas in the viable myocardial scan, it shows activity. So this is how you differentiate between complete infarction, reversible ischemia, and a normal myocardium. The left ventricle is divided into 17 chambers, and you obtain in a circular pattern, you obtain the percentage involvement of the myocardium. This is a patient who had a left atrial myxoma. You could see on the CT image there is a hypoattenuating lesion, which on the PET CT shows activity. Cardiac metastasis, though rare, we have seen in our at least a case per year. This is a patient who had a squamous cell carcinoma of the tonsillar fossa, metastasizing to the interventricular septum. Another patient is a coronal PET image showing a CA esophagus at the lower end involving the gastroesophageal junction. There is a gastrohepatic lymph node here, which you can see. And this patient had, if only a normal CT was done, probably would have missed it out. PET helped in showing metabolic activity within the lesion involving the left ventricle of the heart. Now, what is a delayed scan? Delayed scan, also called as a retention scan. Again, the principle is of glycolysis. We obtain a scan 2 hours after obtaining the baseline scan. What we do is, we look at the SU max. The rate of glycolysis in a normal cell would decrease, whereas in a malignant cell or in those cells which harbor infection, the rate of glycolysis either remains same or it increases, but it does not decrease. So that's how you differentiate these disorders. It is a specific, it is sensitive but not specific, because in both tumors as well as infections, we can see a high retention index. The retention index should be more than 25% of the baseline. So where do we use it? We use it in case of lymph nodes, especially whether this lymph node is reactive or pathological. Of course, ultimately, the gold standard is obtaining a tissue biopsy. But yes, it can tell you whether these lymph nodes can be followed or not. At the same time, we look at the morphology of the lymph node on CT or on ultrasound. They should be rounded, not necessarily size. Even today, we have seen micrometastasis occurring in subsentinel lymph nodes. There should be loss of central fatty hilum. In case of tuberculous lymph nodes, you may have caseation or matting, or you may have central necrosis. Here, I would like to say that in case of squamous cell carcinoma or metastasis to lymph nodes in the neck, you will also get caseation. So don't mistake all necrotic lymph nodes for tuberculosis. It can occur in long-standing lymphoma. It can occur in squamous cell carcinoma metastasis. Now, this is a patient who has hypermetabolic lesions in the interventricular septum and left ventricle of the heart. Delayed. In addition, if you see the PET images, you can see lymph nodes in the supraclavicular fossa as well as along the paratracheal region in the bilateral hilum. So it's always a conjunction. We look at the CT, we look at the lung windows, we look at interstitial lung disease, we look at nodules. So these all in conjunction we come to a diagnosis. Oncology forms the mainstay of all PET studies. It's mainly used for diagnosing and staging, planning, treatment planning, especially in radiotherapy, where we measure the tumor volumes and we assess these tumors post-treatment, whether they have reduced in quantum or not. Response to therapy using the RECIST criteria or the modified PERCIST criteria. And in those patients whom there is recurrence, we do a restaging and detecting recurrent lesions. Initially, there were only 6 or 7 indications for PET-CT in oncology, but today we are using, probably for all malignancies, we are using PET-CT. One is that it's easily available. Second, cost-wise, it has almost become the same. Now, coming to head neck cancers, this is a patient, an axial image. You can see there's a bulky mass which is involving the lateral border of left lateral border of the tongue, extending posteriorly to involving the part of the base tongue. On the PET image, on the fused PET image, you can see as areas of metabolic activity. This patient had a small left suprahiatal level 2 neck lymph node. Now, another patient, if you see, this is the section at the level of the true cord. The disease is involving the anterior commissure. It is involving the anterior aspect of the bilateral true cords. The overlying strap muscles are involved. Also, the disease is causing erosion of the right thyroid cartilage. So why is this important? Because involvement of the thyroid cartilage changes the treatment. If the thyroid cartilage is not involved, then you can probably go for a laser surgery if the lesion is small. If the thyroid cartilage is involved, then you go for a radical surgery, like total laryngectomy. Now, another patient who had a diffuse mass lesion in the piriform fossa, right side, bulky disease, post-concurrent chemotherapy, radiation therapy, there was complete resolution of the disease. In case of thyroid cancers, we mainly use it for anaplastic of polydifferential cancers. Yes, we have been using it for papillary carcinoma of the thyroid gland, for mainly assessing metastatic disease to the lung, liver and bones. If you see here, the entire thyroid gland is involved. It is infiltrating into the cartilage of the trachea. You have a metastatic supraclavicular lymph node. You have lung mets. You have bulky mediastinal lymph nodes. Now, another patient who had a diffuse infiltrating type of malignancy involving the infracanal esophagus, going just short of the GE junction. Another patient, supracanal esophagus involvement, right retroclavian lymph node. Also, you can see metastatic lymph nodes in the bilateral hilar regions, subcanal region, and there are pulmonary metastases. So this is a one-stop investigation for assessing and staging of cancers. Bulky disease, again, you can see that the long segment of the supracanal as well as infracanal esophagus is involved. Surprisingly, you see the lymph nodes in the abdomen. You don't see it in the chest. You don't see any lung. So this is all what we call as tumor biology, which has been changing today. We look at neoangiogenesis. We are looking at genetic behavior of the tumors. We are looking at markers, the NGS. Another patient who had esophageal cancer, received concurrent chemotherapy, radiation therapy. If you see, this is the pre-treatment scan. Post-treatment scan, there is very residual disease. So in these patients, if we calculate the SUV max, it will be less than 25%, telling us good treatment response. Coming to solitary pulmonary nodules, this is very commonly encountered in our day-to-day practice. When you see, as clinicians, you see chest X-ray, you don't know what is it. Is it a granuloma? Is a tuberculoma? Is it a old healed lesion, or it is a malignancy? So what we do is we characterize the lesion on the CT. If you see that it has irregular sphincter margins, it is bronchocentric, it is along the vessels, and when you do a PET scan, this lights up. So the advantage of PET here is we can target the lesion for biopsy, avoiding the necrotic area so that you don't get a false negative tissue. Another patient looking like a solitary pulmonary nodule, but when you do a PET scan, you see multiple lymph nodes. So this patient was downstage, was an adenocarcinoma. Please remember that all peripheral carcinomas, unless proved otherwise, are adenocarcinomas, where those which are central are squamous cell carcinomas. Again, bulky lung lesion, but no contralateral metastasis, no lymph nodes, but on the PET, you see that there is an adrenal metastasis. So the stage 4, it becomes a stage 4 disease. Again, we know that this patient is not operable. Patient is on osimertinib. You have a lot of immunotherapy drugs which are being given, targeted therapy is being given for malignancies which are immune. The average lifespan, which was initially 6 months for stage 4 cancers, is now almost 60 months. Recent studies have shown, recent trials have shown that the average survival of stage 4 breast cancers, lung cancers is about 5 years or 60 months. What we look at post-response is, you see this is pre-treatment, there's a lot of activity. Post-treatment, we assess the SU max and you see the quantum of viable tumor. Almost 75% of the tumor has become necrotic secondary to post-treatment changes. What you do basically is reduce the blood supply to the tumor. Initially, they used to scan only stage 2, stage 3, stage 4 breast cancers. But today, we have been seeing a paradigm shift where patients of stage 1 cancer are also being scanned, especially those tumors which are triple negative, which are aggressive disease. We have also seen certain small quantum of breast cancers, which are the primary disease is small, but we have got metastasis to the bone, liver, or lung. So now practically every patient who has been diagnosed with breast cancer undergoes a PET scan. Now this patient had a lesion in the right axillary tail and small lymph nodes in the axilla. Like I mentioned earlier, the sensitivity and specificity of PET-CT for lymph nodes is only 50%. Ultimately, you have to do a sampling. The problematic areas are of lymph nodes in the mediastinum and subcranial regions. So if you have disease in the breast and you have disease in the mediastinum, what the oncosurgeon does is that he asks the chest guys to do a EBUS, that is endoscopic ultrasound guided biopsy of the subcranial lymph node provided, or hilar lymph node provided it is biopsyable. Again, bulky breast mass with a metastatic left internal mammary lymph node. And this patient also has brown powder fat in the nape of the neck, should not be reported as supraclavicular metastasis. Again, if you see, I had mentioned earlier, small breast lesion, but developed metastasis to the sternum and liver. So this changes the treatment modality completely. We still have surgeons who don't follow the dictum of doing a staging PET. They just get a chest X-ray done and they do a bone scan in the city of Bombay, and then the patient comes with recurrence of disease within 2-3 months. So my sincere advice to all you budding clinicians or radiologists is that please advise your colleagues or relatives or friends to get a PET scan done as a mandatory for any tissue-proven malignancy. Lymphomas, of course, goes without doubt. It is the staging modality for disease above and below the diaphragm to look for involvement of the liver, spleen, and any other. We can have lymphomas in any organ, including pancreas and brain, of course. So here, if you see, you have a bulky nodal disease in the right suprainferior neck, left suprainferior neck. There are also lymph nodes in the chest involving the mediastinum as well as in the portal hepatis. We use what is called as the Duval score for treating post-treatment analysis of patients with lymphoma. Now, if you see this image, you have seen that every nodal station in the body is involved from neck to pelvis. There is extra nodal involvement of the spleen and liver, as well as involvement of the bone. Now, this patient is a stage 4 lymphoma treated with R-CHOP. Multiple regimens are there. So post-treatment scan shows complete resolution. So what we use is the Duval score, where if there is no disease, it's Duval 1. If the SU max of the lesion is more than that of the mediastinum, in the mediastinum I mean we measure the SU max in the arch of the aorta, it is labeled as Duval score 2. Duval score 3 is where we measure the SU max in the right lobe of the liver or segment 6. If the SU max is more than that of the aorta and less than that of the liver, it is Duval score 3. So 1 to 3 are labeled as complete response, whereas 4 is the activity is more than that of the liver, and 5 is where you have new lesions coming up. So Duval score is a method of prognosticating the lymphomas. Again, like esophageal cancers, it is now being commonly used for staging gastric cancers. And if you see here, the patient had a diffuse thickening involving the mid body of the stomach. This is the CT image showing this, showing activity here. Had multiple metastases to the liver, which are seen as heterogeneous lesions. And we also have a lung met in the left lower lobe. So this was a patient with a stage 4 gastric cancer. Again, in case of hepatobiliary cancer, we used to only use MRI and CT. Today, we are using PET for staging. If you can see, the gallbladder is diffusely involved. The reason we do PET is to look for contiguous involvement in the segment 4B and 5 of the liver, because then the patient goes for radical cholecystectomy. We also look for nodal metastasis. But if there is peritoneal disease or disease elsewhere, where it gets classified into stage 2, stage 3, stage 4, then you give neoadjuvant chemotherapy, you give targeted therapy, downstage it and then operate. And here I'd like to mention that most of the tumors, except if they are less than 2 centimeters, pancreatic tumors or gallbladder tumors confined to the gallbladder, any tumor which is outside, the recurrence rate occurs within 15 months. That's how aggressive these tumors are. Now this patient had if you see this patient, there's hardly any mass. You can just see a bulky pancreas. So you would have probably missed out this tumor. But when you do a PET, you see it lights up. Because the pancreatic tumors on the CT are hypoattenuating or poorly enhancing. What is clinching is the vascular encasement. If you see here, this is the celiac trunk. You have the common hepatic artery dividing into the left and right hepatic artery. Here you have the splenic artery and vein. So, and you also see the lesion has infiltrated the peritoneal surface of the spleen. So, when we report hepatobiliary pancreas, we look at the primary tumor, we look at the locoregional extension, the vascular involvement, the nodal disease, and distant metastasis. Again, hepatic SOLs, there is multiple differential diagnoses amongst the malignant tumors. You can have a hepatocellular carcinoma, you can have an adenocarcinoma, you can have an intrahepatic cholangiocarcinoma. Yes, you have a triphasic CT which classically shows you an enhancing tumor in the liver, which is supplied by the hepatic artery, right or left, depending on which lobe it is, and it shows avid enhancement in the artery phase. In the portal venous or delayed phase, there is washout of the contrast. So the newer guidelines are that if you have one modality with elevated serum alpha-QT levels or PUCA2 levels, then don't do a biopsy. If you have two modalities, either MRI or CT or PET-CT, with normal PUCA levels or normal alpha-QT levels, even then you don't do a biopsy. If the patient is operable, you go straight away for a hepatectomy or a wedge resection. If the patient is not operable, then you can probably start immunotherapy. Or if the patient is fit for transplant, there is no distant disease, involvement only of the liver without any portal vein tumor thrombus, then you can go for a transplant. This patient had a pretty large mass lesion involving the segment 4AB, spilling minimally into the lateral segment. It shows areas of necrosis. Your differential diagnosis would be first intrahepatic cholangio and then an adenocarcinoma. It is also being used very commonly in colorectal malignancies. You can see this patient had a malignancy in the rectum in the form of thickening, also had a synchronous lesion in the ascending colon. So this patient had extensive liver metastasis, non-resectable, so this patient goes for palliative treatment. In gynecologic malignancies, we use PET scan in conjunction with MRI. MRI is done mainly for looking at the breach in the serosa. You look at the loss of endometrial myometrial interface. But PET-CT is for involvement. If there's extracellular involvement, whether the rectum is involved, bladder is involved, is there any ureteric involvement, are there lymph nodes and distant metastases. So if you see, this tumor has completely involved the endometrial myometrium, it has breached the serosa. So even with PET-CT, it is possible today now to comment on the breach in the serosa. Patient had metastatic lymph nodes in the retroperitoneum. Again, a patient with bilateral cyst adenocarcinoma of the ovaries, typically the cystic component will not show any enhancement, whereas the solid component bilaterally would show any. So when we report CA ovaries, we look at the choroidal veins. Again, we look at peritoneal disease, whether it's operable or not operable. Look at the lymph nodes, look at hydronephrosis, hydroureter, look at liver metastasis in lung and bone. So that's all. If you see this patient, this is a PET image. Unfortunately, had developed lymph nodes in the chest, had a subdiaphragmatic lymph node, and also had lung nodules. So this is a patient with stage 4 CA ovary. Again, small disease burden involving the cervix, not involving the parametrium, not involving the lateral pelvic walls, but presented with liver metastasis. So it changes your management completely. So, of course, for the clinician and for the surgeon, this is not a good sign because they lose a patient. But I think for the patient, we stage properly, the patient is treated well, and the prognosis is always better. In case of soft tissue sarcomas, like I mentioned earlier, again you have to do an MR here to look for involvement of the nucleovascular bundle, look at the muscle involvement. In case of PET-CT, we don't do it mainly for local, we do it mainly for distant metastasis to the lung. We have also been seeing a lot of sarcomas metastasizing to the popliteal lymph nodes and inguinal lymph nodes. We used to always think sarcomas don't go by lymph nodes. No, it's not that. We have seen patients who have got lymph nodes which are not very large, 1.2 centimeters. We have done biopsy for those patients and they have turned out positive for metastasis. Now there are certain studies which show that if the SU max of a sarcoma is low, then it corresponds to the histological low-grade sarcomas. Whereas if you have high SU max, those are anaplastic sarcomas or high-grade sarcomas which have poor prognosis. Now, how do you assess the treatment response? So, what we use are, if the patient has come post-treatment, whether like in lymphoma that I showed you the slide, whether there's complete response, or if there's partial response, means the number of lesions have gone down, the activity has gone down. There's something called a stable disease. That is when you're performing a third or fourth scan, you see that the lymph node earlier was the same and now it is same, no change in size, no change in SU max, no new lesion. So it becomes stable disease. What is progression? Anything new or any old lesion with increase in size and activity SU max is considered as progression. So we use the PET criteria or we use the RECIST criteria. When we are using we prefer the PET criteria because it's easier for the clinician to understand. Yes, what the clinician faces is that when most of these targeted and immunotherapy are very expensive, costing lakhs. Sometimes because of tumor biology, change in biology, mutation, the patients don't respond. So we have stopped. What we give in our reports is the finding. Suppose if I give that the disease has progressed, what the patient thinks that the disease is, the wrong treatment has been given. So it's very important for us as radiologists how we frame our words. So many a times we unless there's a good response or there's a partial response, stable disease, we tend not to mention disease progression because on the Indian patient it has a psych where they think that nothing is working. Now coming to the next common use which I have been using is fever of unknown origin or pyrexia unknown. Initially the definition was said 15 days, but today any patient who is admitted with 4 days without any knowing cause, we have realized that this is very important method of finding the source of infection. For an infectious disease specialist, this is a very good modality. Can be, like I said earlier, can be done in the presence of raised creatinine also. If you see this patient if you see the image on the CT, if you see this is a consolidation lung with a cavity and intracavity soft tissue. So this was a case of an aspergilloma. We all know what the opposite infections are today. We have PCP, we have other fungal infections. We are seeing a lot of patients with fungal infections because patients are undergoing transplant or have received steroids. We are seeing patients of mucormycosis, post-COVID steroid therapy. So this is a good way of assessing infections. Now in patients with inflammatory bowel disease like ulcerative colitis and Crohn's, those CT can give a diagnosis. But whether this patient is in remission or has relapsed, how do we assess that? What we do is we perform a PET, we look at the thickening and we also look at sometimes you may have thickening only because of edema. Edema is seen in patients with CRF, it is seen in patients with liver disease and also with cardiac, where it may be a part of anemia, hyperproteinemia or even anosarca. But whether this edema is got infectious foci is by assessing the activity with the thickened walls. We all know that ulcerative colitis has got skip lesions. You start from the rectum going right up to the ileocecal junction. Whereas in Crohn's disease, today Crohn's is being diagnosed more and more, like sarcoidosis is being diagnosed in the Indian scenario because of good histopathology, good imaging modalities, and like the first talk, the gastroenterologist must have mentioned about the ileocecal lesions. So what we are seeing, 3 commonest lesions or 4 commonest lesions which can involve the ileocecal junction in Indian scenario is tuberculosis, Crohn's, chronic enteric fever, lymphomas and adenocarcinomas in that order. But lymphomas classically have aneurysmal dilatation of the bowel because of the sympathetic involvement of the nerves. And they may also be associated with bulky lymph nodes. Now, if you see this, finding on the CT coronal image, very subtle hypotenuria, which we classically describe as wedge-shaped striated nephrogram. But luckily, PET was done for this patient and this was lighting up. So this was a case of pyelonephritis, and this patient had reactive lymph nodes or inflammatory lymph nodes in the parotid region. So every lymph node in the body need not be tuberculosis. They can be reactive, they can be inflammatory, it can be a part of Kikuchi's disease, it can be because of reactive lymphoid hyperplasia, Castleman's disease, or lymphomas. Another aging population in India, we're seeing a lot of prosthetic hips, knees. Now this patient had persistently elevated CRP levels, low-grade fever. Obviously, the first source of infection should be the operative bed. But how do you make it out? You can't do an MRI because there are metallic artifacts, processes, they're contraindicated. So you do a CT. We have what is called as the MAS protocol, It's a software which called metal artifact reduction software, where you can get rid of the artifacts because of the software. And if you see this PET image, it shows uptake in the acetabulum, suggesting that the infection had crossed from the prostate environment to the acetabulum. Another important area which we are using PET scan is in case of patient with giant cell or what you call large cell and large artery and middle artery arteritis. Now what happens on a CT? You just see thickening. That's all. And that thickening is going to persist for the entire life. So what we do is we do a PET scan and we see the activity in the walls. Why is this important to the clinician? Because they have to start targeted therapy or they have to continue with steroids. If there is no activity, they can stop the steroids and put the patient on maintenance therapy. Now, like I mentioned about orthopedic disorder, we also use PET for detecting skeletal metastasis. It is better than bone scans and also in evaluating patients with diabetic foot. Now, this patient, if you see, this is the clinical image. You can see a skin defect here. If you see the X-ray here, this is thickening of the cortex irregularity. There is a metallic implant there, which was subsequently removed. And if you see here, this entire area has got a pathological fracture. So what do we look for in, we look at cloaca formation. You must have read in your anatomy about cloaca and sequestrum, or probably you will learn next year. So what we look at is the dead bone. But the dead bone shows activity on the PET. So this patient requires debridement surgery. Now, just want to show you these two images. This was used, PET CT for use for detecting extensive skeletal metastasis. This patient had a squamous cell carcinoma. And here is a PSMA PET CT showing, again, metastasis. So how do the metastasis look on prostate? There's sclerotic metastasis. Whereas in case of squamous cell carcinoma, you have lytic metastasis. In breast, you have lytic metastasis, or you may have mixed metastasis. In cases of CA breast post-therapy, that is radiation therapy, chemotherapy, these metastases become sclerotic. In case of hematological malignancies, we use it for bone marrow involvement in leukemia and lymphoma. I had mentioned earlier myeloma, we have classical lytic punched out lesions on the CT study. Usually myelomas have low activity compared to the other tumors. And we also have amyloidosis and sarcoidosis where we use this for now, diffuse marrow uptake occurs in leukemia either because of the disease or because of extramedullary hematopoiesis. Now, in what are the emerging trends and research applications? Mainly, we are using this for theranostics. Where do we use this? We use this for treating. We all aware that we use iodine-131 for treatment of thyroid cancers. We ablate the tumors. Same thing we are using for. We are using 177 lutetium for treating neuroendocrine tumors, those which are extensive multicity you cannot operate. We are using this for treating prostate cancers, especially those patients who have got bone metastasis. So what happens? This radio tracer gets selectively deposited in the tissue and it reduces or cuts off the blood supply to the tumor. We also, other way of assessing in patients with immunotherapy is that we want to look for progression from pseudoprogression. Why does it occur? Pseudoprogression occurs because there is something called a systemic immune response syndrome. And there what happens, the lesion flares up, the size increases. But the moment you stop the treatment, it comes back to its original size or reduces. So you know that this is pseudoprogression. In true progression, in spite of stopping the treatment, the size remains the same. We are also using today AI in a major way for upgrading the software as well as the hardware, like I mentioned earlier. And there are certain which are in the research stage is where they are assessing the myocardium and the heart as a total for chemotherapy-induced myocarditis. Like I mentioned here, you have a baseline study. It shows pseudoprogression and then treatment after this thing. There is a decrease in the such lesions. Now coming to a concluding slide. What are the take-home points? One is, it is a one-stop investigation where you can scan head to toe, You've got various modalities, various applications of PET CT and indications. Third is you can assess it for diagnosing, staging, assessing tumor response. It is important to know whenever you write a prescription, it is important to know what radiotracer is required. We get even now oncologists who just write a PET scan, but the diagnosis is important and what radiotracer is to be used is important. And last but not least, we as radiologists need to be clinical radiologists so that you can think from the clinician's point of view. What do they want? What does the surgeon want? He just wants two things: operable, inoperable. What does the medical oncologist want? Is the tumor progressed? Is it same? Or is completely restored? And to a clinician, to an internal medicine person, what is my source of infection? Yes, they do come to us where they try to tell us what the organisms are. We try to localize it. There is a particular appearance of mycoplasma on CT. There is a particular appearance of certain fungal infections on CT. There is a classical appearance of PCP, aspergilloma on CT. Thank you.
Thank you, sir, for a very Thank you so much, sir, for a very nice presentation, and we are so lucky, and our students also, I would say, because I saw the PET scan for the first time at age of 51, which they are 3 times younger.
We have
than
seen the PET scans, but only of patients randomly.
Yeah.
But today, actually, you bridged the gap between anatomy and PET scans.
Yeah,
How
yeah.
you are doing it?
It was the images, that whole collection, and this is going to be there on YouTube now whenever the students are exposed to more clinicals. Yeah, they
You all are
really
lucky to be exposed to this kind of application of anatomy and the knowledge what sir has given today, so that you can now focus your studies accordingly, that how anatomy is helping in every field of radio imaging. So this is, I think, a very
that high metabolic activity, which, and for 2 minutes I thanked my slow metabolism also. So,
एक चीज मेरा मिस हो गया, मैं अंदर बाहर हो रही थी.
madam, you can come here and
नहीं,
ask
नहीं, बस ठीक है,
because the audience who are there on the webinar can also.
No, but I think sir must have explained
That brain, you said, has high uptake.
Yeah.
So if there are any lesions in brain, then what are you using?
See,
Because I must have missed it. You
See,
have
what happens
explained
is,
it,
I mean, because of the MRI, we normally don't characterize brain lesions on metastatic lesions or infection lesions on PET. If easily detected, well and good, but we don't use it for diagnosing. The activity typically in the brain, the glycolysis decreases after 2 to 3 hours. Same thing with the myocardium. So you have to give high glucose levels to reduce the normal myocardial activity. So that's the principle. And today I would say, if you say today, what is radiology? It's an amalgamation of anatomy, pathology and imaging.
Yes.
So we have, if you see MRI, you have functional imaging, you have anatomical imaging and you have metabolic imaging. So that's how PET MR is. PET MR for the body, there are only 2 machines which have been installed in the entire India. Probably the cost of that MRI machine is 51 to 60 crores. So, and plus the time to scan the patient goes about half an hour. Whereas today we are using machines where the scan time is less than 10 minutes for a PET scan. And we are also using a new radio tracer, of course, come last, it's called as FAPI. That is Fibrogen Activation Protein Emitter PET, where the time of waiting is only 10 minutes. And it is good for those tumors where the which are low activity, like signet ring tumors and sarcomas, they light up like anything. So you will see that the mismatch, you see the tumor markers are rising and you see that there's nothing on the PET scan, FDG PET scan. So whether to change the line of therapy, to start new therapy, or just leave it as palliative care, this FAPI has changed the...
Thank you so much, sir. Also, one more note before we break for lunch. heart is one organ, I think, where we very rarely see any involvement of cancer. So just be active like the heart, which is always active. And
Sir showed that there were.
yeah, there were some involvements, very good. But otherwise, the least organ which is affected in cancer. So we'd like to felicitate sir.
Actually, we've seen a pancreatic plasmacytoma, only 7 cases.
Oh my God. Pancreatic.
Very good case.